is here with us as well. Thank you so much. And still from across the African continent, we have Dr. Nanthalilali Mogala from Zambia. She's here with us. Good to have you, madam. Greetings all the people in Lilongwe and all. It's always delightful when you come from the east and you go down south and you engage the people on that side. Again, I want to welcome in a special way all directors and commissioners from the Ministry of Health and other development partners. Let's clap for them. Now, this one is going to be extremely a big, huge request. I want all of us to join our hands and welcome the district health officers in this room with us. Let's clap for them. You guys do a tremendous job. I can't thank you enough. Every time I travel around the country, when I go to the districts, I say, can I talk to the DHO? And you can clearly see they're doing quite a lot of work. It's alas from the media side that we don't give you the coverage that needs to be done, but well done. You've done incredibly great. Ladies and gentlemen, without any further ado, I want to highlight how this conference is going to move. These are some of the issues you need to know. For those who need the restrooms, you'll have to go downstairs. The way you came, just take downstairs, then you take your right. That's where the restrooms are. Secondly, our password was shared, but as a media practitioner, if you're not using your internet, please put off your data. Just put off the Wi-Fi if you're not using it for anything. Data harvesting is a new business, just so you know. And I want to encourage interactions. I know we have so many Zoom meetings going on and different engagements, but please engage with the people next to you. At least get to know their names. For starters, just know your neighbor's name. Do you know your neighbor's name? Ask your neighbor's name. Ask your neighbor. Talk to do you know your neighbor's name? The same way you ask us what's your name when we come to the health centers should be the way we are operating here. Yeah? Need to know one another. Ladies and gentlemen, allow me to welcome the chairperson of the organizing committee, Mr. Venancio Ahabwe, the technical advisor of USAID, as well as SCBA, to come and give us the objectives of this conference at the end of it all. Let's welcome Mr. Ahabwe to give us the objectives.
Conference convener, Dr. Kabanda, directors, commissioners, assistant commissioners from the Ministry of Health, and all the other sectors of government, our keynote speaker, and other speakers that are going to talk about the different tracks of this conference, representatives of local governments. Those include district health officers and district health educators and other officials from the local government, representatives of partners, implementing and development partners present. Ladies and gentlemen, all protocol observed, I have the duty, the brief duty, to present the objectives of this conference. But before I do, I want first to introduce myself. My name is Venancio Ahabwe. I work with the USAID Social and Behavior Change Activity, known as SBCA, in Uganda. It's implemented by a consortium led by the Johns Hopkins Center for Communication Programs and I see the chief of party and the entire team here. Thank you for being here. I have been the chairman of the organizing committee. Allow me also, before I present the objectives, to recognize the team that has worked tirelessly to make this conference successful. I've been the chair, and the co-chair is Mr. Tabule Bachaita Basajate Badiba. What a name. I don't know if he's nearby. It's a good name. I think we need more of such names. And also, we had a number of people playing different roles, and they are all over this place working still. We had the different committees, including the Abstracts Committee, which gave guidance on how to develop the abstracts and reviewed the abstracts that were submitted and approved those that are going to be discussed in this conference. We have the Event Management Committee, who are also managing this process today. The Publicity Committee has also been working hard. The Resource Mobilization Committee, the Finance Committee, and we had also the Secretariat based at the Ministry of Health. All the team members, why I'm not calling them forward, they are busy working, and I request that we give them a hand clap. I'm waiting for my slides to be displayed, but it has been a great pleasure and an enriching opportunity being part of this process to convene the second National Health Promotion and Disease Prevention Conference. This conference has been organized under the theme Strengthening Primary Health Care through Sustainable Health Promotion and Disease Prevention Approaches. That's the main theme of this conference, with different sub-themes which are going to guide our discussion during this conference. Sub-theme 1, which we also call the track, is strengthening systems for a resilient health promotion and disease prevention agenda. Sub-theme 2 is building partnerships and expanding networks for holistic health promotion. Sub-theme 3 is putting people at the center of sustainable health promotion and disease prevention. And lastly, sub-theme 4 is strategic health communication for early detection of diseases, drawing lessons from the HIV response. The specific objectives, why we are here and why we organized this conference. One is to conduct a dialogue about the specific desired, practical, and effective approaches to adopt and apply for a successful health promotion and disease prevention agenda for Uganda. So while we are here, we are all invited to participate in this dialogue, in this conversation, and come up with what can help us do better. Number 2, this is a synthesis of lessons learned. Many presenters are going to present, and we have lessons learned, best practices, innovations, and recommendations for sustainable health promotion and disease prevention in Uganda. And objective 3, the last, we are going to have, it's a critique of the operating environment for health promotion interventions and discussion of mitigating measures. Those are our objectives for the conference. I thank you.
Thank you so much, Chair. That is our Chair, and the different thematic areas he has alluded to. Kindly pay note in the breakaway sessions that you don't miss any of those. We have our colleagues who are following this conversation online. I love the digital lane. So if you're one of those who is on the digital lane, the hashtag is second NHPDR conference. That is the hashtag on Twitter. If you're tweeting anything from here, and those who are following this conversation on Zoom, we want to welcome you and thank you so much for being part of this conversation. One thing for sure is we'll be picking some of your feedback from the chat room and we'll be reading them a little later. Ladies and gentlemen, allow me at this juncture, I'm very honored to invite the conference convener, Dr. Richard Kabanda, the Commissioner, Health Promotion, Education, and Communication from the Ministry of Health. Dr. Kabanda. We clap for him. He's the convener.
Our keynote speaker, the country representative for UNICEF, who is also our keynote speaker for one of the tracks, the mission director, Mr. Richard Nelson, Professor Omaswa, our Director for Public Health, Dr. Daniel Chavainze, our colleague from NMS, who is here to give us a brief presentation, some key insights on why we need to change our focus from curative to preventive and promotive health. Moses Kamabale, our colleague from the Ministry of the Commissioner for Emergency Medical Services, Dr. John Baptist Wanyaye, other senior colleagues from the ministry, the development partners, the number of chiefs of party here from different institutions, the implementing partners who are here, the media, our senior colleagues from the districts. More so, I know we have some political heads here. I hope we have some other DCs here. The DHOs who are here, the DHEs who are here, the selected DCDOs who are here, and other colleagues who have joined us. Ladies and gentlemen, you're most welcome. This is our second conference focusing on health promotion and disease prevention. Our first conference was there in the year 2019. We had agreed that even after 2 years, we would be having these conferences organized. But because of COVID-19, 2021 was a tricky year. Many colleagues here wouldn't allow to be in this room. So there was need for us to postpone and have this conference this year. Allow me to let you know that before I go into the details, I'm here to share with you some insights on the commitments or resolutions we made in 2019, provide you with the updates on some of the key commitments and some insights to enable us to be able to move when we know some of the key achievements as a result of the conference that we had in the year 2019. So the background to have national level conferences. One, as I said, is the desire to move away from the focus on curative, because we know that 75% of the diseases we have in our country, and of course many more other low and middle income countries, are preventable. So there has been a lot of medicalization of public health, as we may say it. I know Professor Maswa will speak about this so much because he has been singing this for so many years. There has been a lot of medicalization of public health. Even when we document that we need to move away from focusing on curative to promotive and preventive, we have not seen that coming out practically in our actions, in our planning, and in our implementation. Thus the desire to ensure that we have a national platform where we can have technical discussions on a number of things. The need to prioritize or to focus on promoting health and preventing diseases, because Uganda is a poor country, we cannot afford to be investing all our resources into curative. We also know that there is inadequate funding for health promotion and disease prevention interventions. Our colleagues who are coming from districts can attest to this, that most of the resources they have for paying salaries of health workers, or they are skewed towards Dr. Moses Kamabale's area. And then the other area which really fosters is the desire to shift from disease-specific advocacy engagements. Those of you who have been following trends within the health sector, most of the conferences, most of the dialogues, most of the stakeholder engagements are disease-specific. So today they call you for malaria, the other day it will be for TB, the other day it will be for HIV, the other day it will be for diabetes. We have so many diseases, and we said we cannot continue having disease-specific discussions. We need to have harmonized discussions at least once a year or once in 2 years, so that we consolidate our energies and efforts to ensure that we are able to achieve more when we move as one team. So from the year 2019, those of you who were with us here, that time the theme was skewed towards strategic investments in health promotion to achieve universal health coverage. That time, our keynote speaker came from Kenya, the CEO for AMREF. He did share with us a number of things, and I'm happy that some of the key things which we discussed from that meeting have been taken on by government or by the Minister of Health. But we are saying that there is quite a lot that we need to do to ensure that this area is strengthened, to also ensure that we fully promote health of our people in the communities. So at that time, we did make a number of commitments, and allow me share with you some of the resolutions that we are taking and the progress so far for a number of resolutions. We did decide, of course, from the participants that we should be having a 2-year engagement. I have already explained why last year we were not able to meet. We were tasked by this House that time that we should develop a harmonized health communication strategy. I'm happy to report to you that we did receive money from UNICEF. UNICEF gave us, I think, close to $100,000. We developed the strategy, and one of the reference materials on your tables, one of the documents you have is the harmonized or comprehensive national health communication strategy. There was also a desire to revise mechanisms on how to promote antenatal care as one of the ways how we'd be able to prevent maternal death. Because most of the participants that time indicated that most of the mothers do not actually go to health facilities, or they get to health facilities late. That time we are talking about 4 antenatal care visits, and we realized that ANC attendance, especially for first ANC attendance, was actually very low. So there was need for us to ensure that we try to revise mechanisms how best we can promote ANC. So with support from UNICEF still, we have been able to develop an operational plan, which is also on your tables, on how best we can promote antenatal care services in the country. Since Dr. Munil is here and is passionate about health communications, now that the plan is already developed, it is on your table, sir. One of the resolutions which I'm looking forward is to ensure that we operationalize this plan. We need to invest more in communities. We need to give money to districts to ensure that this area is strengthened. It's one of the ways how we can best promote the life of mothers and that of children. The other key issue was to develop an online platform that will enable easy access of health promotion materials. That time, the discussions around this area, it was very clear that as a country, we had no platform where people could easily access promotional materials that have been developed. And we know you cannot talk about preventing diseases when health literacy levels are low. One of the ways how to increase health literacy is to ensure that the population is well guided on which kind of information they consume. But access to this information was really a very big challenge. It is still a challenge. So every time we have outbreaks, people get to the Ministry of Health to share with them approved content, which is tedious on our part. So we said that it is better for us to have an online platform, feed it with all the content that has been approved by the ministry so that partners can quickly be able to access this information, share it with districts. The same for the districts, they can easily share this information, access it from an online portal, and be able to use it to engage members of the community. So with the support from USAID, we have been able to develop the Uganda Campus for Health Promotion, which I think that the Minister of Health will be able to launch today. And that online platform, members of the public, our district colleagues, IPs, and development partners will be able to access it to look out for most of the content or approved strategies and plans from the sector, some of the research that has been conducted by academic institutions, our operational research in the areas of health promotion and prevention. We had fruitful discussions with the academia at that time because we also realized that most of the research undertakings, they are skewed towards clinical, most of them. So we had fruitful discussions on how best this area can be supported to ensure that students who are undertaking, especially public health at graduate level, postgraduate level, can be able to do a number of research in that area. So we shall be able to take you through how to access a number of materials from that portal within these 2 days. The other area was to support community health workers with simplified messages to enable them engage communities better. We realized that some of the key issues that came up, that we are sending out a lot of content to the public, so sometimes it becomes difficult for our community health workers to synthesize, especially if the messages are too many in terms of paperwork and all that. So we received some funding from USAID through UHSS to develop a consolidated community health education handbook. A copy is on your tables. So in that consolidated handbook, we have been able to simplify a number of health messages, especially some of the common conditions and diseases we have in the country. And we hope that now we have this version, which is in English. We expect to have some of this content translated in the common languages. We hope that that task will be taken on by SBCA. Now that Mr. Richard Nelson is here, that is an area where we need funding. We need funding to translate that content. We need funding to ensure that we do mass production. We need funding to ensure that we engage our community health workers to enable them be able to understand this content better. So we are looking forward to support in that area. The second last resolution was the desire to revitalize the village health teams structure to enable them be able to perform better. Those of you who were here in 2019, you remember that we had a detailed debate on the community health extension workers. And the brief we gave that time, the president tasked us to pilot the choose, and we have a presentation after lunch on the progress. But the president also tasked us to ensure that we revitalize the structure. We have received some money from World Bank under the AMCHIP and UCRE projects to revitalize the VHT structures. We have been able to secure funding for now for over 40 districts. And we know that the essence of that is to ensure that we re-identify VHTs, we retrain them, we keep them with the VHT kits, and ensure that we give them all the necessary materials to enable them be able to engage better at that level. So the VHT structure, however much we are piloting the choose, we want to ensure that our volunteers at village level are energized, are motivated to ensure that they are able to deliver services better at that level. So we are running these as parallel programs for now. We have subjected our teams. We have a number of consultants who are undertaking research. As we pilot the community health extension workers program, we are also trying as much as possible to ensure that the VHT structure is well revitalized. We hope, colleagues, allow me welcome the PS. Madam PS, you're welcome. We couldn't wait for members of senior top management. We knew that you had other engagements, so we decided to start the program. So we hope, as you receive detailed information after lunch, that the different undertakings with support from different institutions who have received funding from USAID to pilot the choose, but we are also running another model with support from COFI. The Korean government has given us some money to run another program in Masakandi, Bukoma, and Simbi. So we are going to do a number of activities in there and research undertakings to enable us to be able to inform the country better on the policy direction regarding the issue of community health workers. The other key issue, which I should end with here, is there was a request from the participants that time to promote men's involvement in seeking healthcare services more so within the area of creating demand for family planning services. The fertility rate in the country is high. We, the men, most of us, have not been very responsive when it comes to issues of family planning, for example, but more so also on promoting health in general. So there was need to develop a strategy, and I'm happy to let you know that we have developed an advocacy strategy for promoting family planning. A copy of this strategy is also on your table. Within that strategy, there was need to look at a number of issues broadly, and there are 14 advocacy issues, and the issue of men is actually one of the issues. So we want to ensure that we operationalize this strategy that has been developed. So we are looking forward to having mutual discussions with the development partners who are here and implementing partners on how best we can push this. So one of the key activities which we are looking forward is the launch of these key documents which have been developed by the sector and approved by top management of the ministry. And we hope that if we use some of these documents very well, it is one of the ways how we are going to advance this area of promoting health and preventing diseases in our communities. So the 4 documents, as I said, they are there: the Comprehensive Health Communication Strategy, the National Health Education, Community Health Education Handbook, the National Family Planning Advocacy Strategy, and the National Communication Plan for Promoting Antenatal Care Services. The other last component which we shall definitely also look through is the Uganda Campus for Health Promotion. So I will not go into details of this because I've already talked briefly about it, but as I said, we shall be able to use this platform to be able to access a lot of information within the area of health promotion and disease prevention. So, Madam PS, we have had a big team. We have had a big team organizing this conference, and allow me to appreciate a number of partners. I will not mention names, but we have received some good funding to ensure that we organize a conference that is similar to the conference we had in 2019. And thank you so much, our dear partners whom we have worked with to ensure that this conference is well financed. So colleagues, ladies and gentlemen, that is a brief of the key resolutions which we took in 2019 and the update so far regarding implementation of a number of activities skewed towards ensuring that this area is well strengthened. Thank you for God and my country.
Thank you. Let's clap for our convener again, ladies and gentlemen. Good to have you, Madam PS. We understand you had quite a lot of competing priorities, but you took your time to be here with us. To the Fourth Estate, I want to be a little bit of a guidance. We're all going to have our cameras set where those cameras are, all of us from the Fourth Estate, so that we avoid a little bit of crossing around. It affects the feed on the other side, especially those following online. Thank you so much. That said, for me, my takeaway was a lot more about the male engagement. Thank you so much, Dr. Kabanda. And when I was in Pattaya, it's one of the issues I made sure that I amplify in the high-level meetings. I'm grateful that as a ministry, we have that strategy to engage the men when it gets to health-seeking habits. But again, you talked about something to do with curative services rather preventive services rather than curative services. On that accord, allow me to welcome Moses Kamabali, the General Manager from the National Medical Stores, to tell us the cost implication of delivery of curative services, perspectives from the National Medical Stores.
Thank you very much, the Master of Ceremonies, Madam PS, the Director of USAID Uganda, the Country Representative of UNICEF, the keynote speaker, colleagues, protocol observed, ladies and gentlemen. When I was asked to say something in this conference, I was wondering what it is that I would say that would make it compelling for the engagements that we'll have today and tomorrow. And I was asked to talk about the perspectives of National Medical Stores in the curative services. We know that what we provide as National Medical Stores is just part of what comprises the curative services in this country. So I limit myself to the funding in as far as the medicines and health supplies are concerned. We also know that it's much beyond this. I will not go into that history. We all know the NMS as being established by the National Medical Stores Act of 1993. We have the objectives, why we exist. We'll have an opportunity to look at that at our own time. Because of time, I will not go through that detail. I would like to talk a bit about what we have been doing over the years. Why? Because I want to say that as National Medical Stores, we've tried to do everything that is humanly possible to deal with the inefficiencies, with the challenges that are within our control, to ensure that we provide the essential medicines and medical supplies to all the government health facilities that need them. We do the handling of the procurement, storage, and distribution of these supplies, both for government of Uganda, but also for the development partner supplies that they give the government of Uganda. Last financial year, we were able to handle about 2.3 trillion Uganda shillings worth of commodities. Just to give you the comparative figures, about 13, 14 years ago, the throughput or the value of the supplies through National Medical Stores was 60 billion Uganda shillings. 60 billion Uganda shillings. "14 years down the road, it is 2.3 trillion Uganda shillings. 35% of the value of these commodities is funded by government of Uganda, and the partners have been giving us about 65% of these commodities. And these things are very important. We serve now about 3,255 government health facilities. That include the army, the police, the prisons, the facilities under the central government, that is Ministry of Health, and those under the Ministry of Local Government. We've improved on our deliveries, the health facilities. We now deliver to the national referral hospitals at least once every month, and to the other health facilities at least once every 2 months. We have a list of close to 1,500 individual medicines and medical supplies that we deliver. For the people that do the procurement in this country, you know how difficult it is to get all these commodities using the procurement systems in these countries. We've sung the song of the PPDAs and the challenges associated with going through that process to get these supplies into the warehouse before we deliver them to the health facilities that need them. We have systems that process emergency supplies even within 24 hours. We have a 2-day, an 8-hour shift. We work during the day, we work at night when people are sleeping, our people are picking and packing the supplies. We have a last mile delivery. We've moved from delivering at the district headquarters and expecting the local government to deliver these supplies to the individual health facilities under the district. We have taken over that stretch. These are part of the improvements that we've been making all this time. Now it is NMS that delivers to each and every individual health facility in the country. We have our regional offices. We have established 10 regional offices to take care of the customer relations. We've had to constitute basic kits for the lower health facilities because of the challenges that we've been having to get orders from them. We are now making further improvements with NMS Plus to ensure that, to the extent possible, all the facilities can place their orders in the comfort of their offices through the NMS Plus, thanks to the support that we got from the people of the United States of America through USAID, NMS Plus. All these are the improvements that we've been making over time. We have, through the efficiencies that we've made over the years, reduced our operational costs from 35%, what it used to be about 15 years ago, to now 7%. What that means is that for every 100 shillings that we get for these commodities, in the past, it is 65 shillings that would constitute the commodities. 35 shillings will be in handling our salaries, fuel, repairs, and all those associated costs. So the medicines out of every 100 shillings will be the 65 shillings. Currently, for every 100 shillings, 93 shillings are converted into commodities. It is 7 shillings that handle our operations. So even within the same budget, we have efficiencies. By comparison, the other warehouses that we have in the region and in the country are handling these supplies at around 18%. The government of Uganda has been increasing the monies that they give to national medical stores over the years. And the partners have also increased the commodities that they deliver to national medical stores. Just as part of the last financial year's throughput, the 1.8 was from partners. So, I think we have a problem with this. Yeah. So that is how we've been handling, we've been getting the figures moving upwards from 2018-2019 financial year up to now in this financial year. We talked about the throughput of 2.3 trillion last financial year, but on the graph you can see 1.258 because the difference is constituted by the commodities that we got as a result of COVID supplies and the vaccines that we got last financial year. So that is the summary of what we are talking about in terms of funding through the financial years. The orange is the need as quantified by the Ministry of Health and the partners. The green is the current funding, is the funding that has been made available over the years. The red is the funding gap that we have had over the years. And we also see the dark green as the government of Uganda contribution versus the light blue, which is the partner contribution. The lower part is talking about the funding gap in terms of percentages. So we look at the need, we are looking at what is available, and we are looking at that gap. How do we finance that gap? So every time National Medical Stores comes to Ministry of Health, goes to Parliament, talks to the development partners, we are looking at how we can bridge that gap in terms of funding. But as you can see, it is a moving target. As they increase the funding, that funding increases both from government of Uganda, from our taxes, but also from the partners, the gap doesn't get closed that fast. It keeps moving. It is a moving target. Just to break down that funding gap in terms of the actual values that we need. We are looking at the laboratory supplies, the supplies to the national referral hospitals and the specialized institutes. We are looking at the value that we need for reproductive health items, ARVs, ACTs. We have the commodities that are regularly required by the level of care, the ones that are not program-based, so they exclude the ones under reproductive health, ARVs and ACTs, the common items. So the health center threes, what is it that they need versus what they are given. So what is the gap? You can see that we have the high gap in terms of health facilities for the common items that they require at the national referrals, followed by health center threes that are the closest to the wananchi. We have general hospitals, health center twos, and then we have health center fours and the regional referral hospitals. And the other programs that we have, the TB program, the nutritional supplements, UNEPI, and their supplies. So, even as the funding gap increases, as it keeps moving, as we increase the funding, the target keeps moving forward. Recently, we have had other challenges that are associated with the cost of delivery of these supplies. Exchange rate. We procure most of these commodities in foreign exchange. So when the exchange rate changes, we are affected. The quantity of the commodities that we deliver to you sometimes reduces, even for the same budget. We've had an issue of fuel costs. We all know at the time when we were budgeting for these supplies, the liter of fuel was around 3,800. Now, it is upwards of 5,000. Remember, we have the same budget. So, for the DHOs that I see here, the directors of referral hospitals, don't come for us. We have the same budget. We were not given even one additional shilling this year this financial year compared to last financial year. And we have to use the same budget to deliver to you those commodities. So the commodities are going to reduce effectively. We used to have an issue of storage space at national medical stores, because when the value of the commodities and the quantity of the commodities increase, the warehouse that we used to have in 2008 for the 60 billion now can ill accommodate or house the 2.3 trillion. So we've had to get additional storage space. I heard the Master of Ceremonies talking about His Excellency the President wondering the place where we built. I was also then a bit concerned, but I was comforted by the fact that there are countries which are built on water. So having a warehouse on water is nothing. It is only the technology. But I was also glad that he talked about 10 years of being there. And I also was comforted by the fact that probably he was only talking about the time he will still be in charge of this country. So after that, probably the next person who will come after 10 years will consider whether we had the appropriate technology to be where we are, or we should move that warehouse. So, why do we say all this? We've been told that about 75% of the diseases that we have here can be prevented. But we are not preventing them. And where does National Medical Stores come in all this? We have done everything that is humanly possible to improve on our side. And what we are currently doing is only one side of the equation. We have been improving on the supply side of the equation. The supply of medicines, give us more money, improve the efficiencies, deliver these supplies better. These supplies, emboss them so that you make it a little difficult for the people who would want to move with them outside of the places where they are supposed to be. All these things that we have been doing are on the one side of the equation, which is the supply side. So we've been improving the supply side. We are here to talk about the demand side. we can agree as Ugandans that even at the current level of supply, we can reduce the demand to meet the supply where it is. And I think that's why we are seated here in this conference. How would we reduce the need for the curative services in our health facilities? 75%, some of the people out there who may be listening to us may think it is a lot of mathematics, you are talking of percentages, but let me bring it down. What this means is that out of every 100 people that you find at the health facilities this morning, every health facility, whether it is government or private, every 100 patients that you find there, 75 of them should not be there. That's what it means. If they did something about what has brought them to the health facilities. If out of those 75 patients, out of the 100 patients today looking for coartem because they have malaria, if they all consistently, very well used the insecticide-treated nets, made sure that they cleared the bushes around them, made sure that they did all the preventive things they need to do, we would only be having 25 Ugandans at the health facility. 75 of them should be at home in their places doing other things. That's what this means. And if it is only the 25 who genuinely should be there that are actually at the health facilities, then, Madam PS, nobody will be remembering you to ask about those hospital beds, because the 75 beds that you are supplying today are not required. The health workers that we are asking for should not be there. The big health facilities that we are asking for are to accommodate the 75 who should not be there in the first case. What, therefore, is our work? We are looking at some of the areas that I've put down here, but I know that the people who are in this room are going to bring up many more areas. I'm looking at things we talked about: using a mosquito net, family planning. If our ladies, if our wives, if our sisters spaced the children between one child and another by about 3 years, we will reduce the number of mothers that are at the health facility now pushing babies. Then the midwives, we will not need those many midwives. Then we will reduce the challenges that are associated with maternal deaths. Then we will reduce the many other things that are associated with the many numbers that come. So, can we, as part of the solution, be looking at allocative efficiencies? How much, if we do our work very well, can we make savings for mama kits and put them in reproductive health items? Because we should not be talking just about getting more money. Give us more money for reproductive health items, for family planning. We can actually get money within and save on the mama kits and plow it into reproductive health items. Prevention of crime, why should it be a concern of this gathering? If the police officers were doing their work well for the past week, with the borders, with the DMC vehicles, with the people who drink and drive, with those people who, how much less of the problem would we have in our health facilities? So, when we are talking about prevention, where are the traffic officers here? Where is Uganda Police in this conference? Are we talking to ourselves? Do we want to come here and package messages and we expect the traffic officers to only listen to it on radio, on TV, look at it on the TV stations? Can't we engage them here? When a man batters a wife, people forget about the man who has battered the wife. They only remember the health worker when the wife is brought to the health facility. When the police officer who is supposed to ensure that that bus that is carrying the 67 passengers is in a good mechanical condition, they get kit kidogo and wave it off. And 10 kilometers down the road, it crashes. There is no Ugandan, there is no member of this fourth estate who are here that will even report about the condition of the vehicle. All they will say is that there were no ambulances. And when they took these people to the hospital, the health workers were not there. And when they were there, the medicines were not there and the supplies. National Medical Stores does not provide medicines and supplies for reckless drivers. The budgets these health facilities have, they are for the routine care. Masaka Hospital is just, they have just quantified their need. All of a sudden, you bring them clients, 67 of them, because of a bus that has crashed in Ruera. Where are the traffic officers that should have ensured that this one doesn't happen? And if us in the health sector do not engage those partners, we will be wasting time. We will not reach our finishing line as fast as we should. So I will expect that in this conference, we think about those areas very critically. Not only that, we talked about the percentage contribution. The taxpayer has given you their taxes, and they are yelling, what is government doing with our taxes? You only need to remind them that their taxes only contribute 35%. They shouldn't actually be shy. They should just be embarrassed. By having a system which is dependent 65% on well-wishers, we are surrendering our sovereignty. But every time we are celebrating our Independence Day every year. This is the worst form of dependency that we have. So what do we expect from this conference? how can we empower the wananchi? We expect that disease prevention, health promotion should be about empowering the people to take back and put in control. Take it away from those people who are giving us the 65% of the commodities, but also take it away from the health workers. Because now our health is in the hands of health workers. Our health should be in our own hands. We have an elder in this room who used to say it better, that health is made at home. You only take it there when it breaks down. We should expect that at the end of our engagement in these 2 days, we give back the wananchi their sovereignty. They should have health in their hands. We need to empower them. In the communication I saw as part of this program that will be dealing with strategic communications, there are things that we need to be talking about differently, even when we are talking about prevention. Family planning. When people are talking about family planning methods in this part of the country, what do they say in Uganda? What do they call the family planning methods? Ekizala gumba. Which wife can go for such? Which sister of yours will go for such? If they are telling you as a lady that what they are giving you is a kizara gumba, will you go for such? Why don't we get better terms to explain what we want to give the people that we need to benefit from these things? Why do we go and tell the mothers that what we are giving you as family planning is to reduce on the number of children that you will have, rather than telling them exactly what we want to do? It is that we are empowering you as a lady to be able to space the children between one and another, so that by the time you have the second child, the one you have had first will have recovered, the mother will have recovered. Why don't we tell them exactly what we want, rather than telling them that we are giving them these methods in order to reduce the number of children that they take? That's part of the communication. That's why our communication to these people is not effective. Do we need to communicate differently? You are telling somebody who is entering a vehicle and you need them to protect themselves, and you say, we want you to wear a seat belt. Does it therefore surprise you when the passenger sits in the vehicle and leaves the belt on the seat? It is a seat belt. Why should I put it on? Why don't we call them safety belts? So that when somebody is thinking about this belt, they ask themselves, what safety is in this belt that I need to take on? We can go on and on talking about these things. My request, the convener of this conference, ladies and gentlemen, is that we do not keep minutes and lose the hours. That at the end of these 2 days, we come out with basic, easy to understand messages that will make us more effective and will rally Ugandans to this call, and we get them on the path of them being in the driving seat of their health. We do not want a time to come when the president, His Excellency, the president of this country, will start thinking of whether he should have another Ministry of Health and keep this one a Ministry of Diseases, and get other ministers to be in charge of that and other. Let us ask our people to meet government halfway. That is all we are saying. That government and partners are coming to you with Coatem. Meet them halfway with a mosquito net. That government and partners are coming to you with mama kits. Meet them halfway with spacing the children. That government is coming to you with more health workers and paying them better. Meet them halfway by doing those things that will keep you away from the health facilities. It is possible, and we can do it. The message that we will be coming out with here is one. And how I wish that this message that we'll take away from here will be the message according, or the gospel according to Saint Prevention. We've had gospels according to Saint John, Saint Matthew. Let today's message and gospel be the gospel according to Saint Prevention. Let us spread it, because that's how all the other messages before were spread. They started with one person to 12 people, and now millions of people know it. It is possible that starting from more than 12 people, if we spread wherever we are going, we should be able to make a much bigger difference. I thank you all for listening to me.
Ladies and gentlemen, let's thank Moses Kamabari again. He came very strong to the fourth estate. I agree, we have fallen short of glory, but we will work better in that agenda. When it gets to the messaging of family planning, I think I heard you so right. I strongly believe in having the messaging, especially that is calling the men to be part of the agenda. Maybe just to inform you, Mr. Kamabale, while we are having the conversation in Pattaya, one of the key messages and the strategies we are having, the international community agreed to switch the models from funding to financing so that we can, be part of the agenda, especially when it gets to health. Inclusion of traffic officers, I saw someone on Twitter celebrating about it. Believe you me, this conversation is going to be sent down to them. In a special way, I want to appreciate the presence of the LOC5 of Bukoman Simbi, Mr. Nyenje Fred Kayira is here with us. Thank you so much for coming, sir. Among us, we have the Mayor of Masaka City, Honorable Namaya Anja Florence. She's equally here with us. Thank you so much for coming. Without any further ado, friends, colleagues, allow me to invite Mr. Richard Nelson from the U.S. Mission to come and give us a statement about strengthening systems for Resilient Health Promotion and Disease Prevention Agenda. Nelson.
It will be difficult for me to follow my friend Moses. I appreciated your remarks very much. And I'm very pleased to see the number of people here. It looks like almost every seat is filled, which is a wonderful thing. Let me just start by protocols. Permanent Secretary, Ministry of Health, other senior officials within the Ministry of Health, members of Parliament that may be present here, the other senior officials from government, from cities and districts around the country. I was pleased to hear so many district health officials in the room. I acknowledge your presence here. Also, I'd like to acknowledge my friend Munir, the country representative from UNICEF, the keynote speaker from PATH, other distinguished colleagues and representatives. Thank you for having me here today. I am grateful to be here to join you to start this conference. I'm here representing the United States government at this second National Health Promotion and Disease Prevention Conference. And it's important that we're all here as we gather to discuss strategies for building health systems and achieving universal health care. The government of Uganda has partnered with USAID for decades, and we've achieved great outcomes together. And I praise the government of Uganda for the way that they've faced challenges and still strive for optimal health for all Ugandans. And we're very grateful for this partnership that we've had over the years, which continues even today. With this partnership, we've learned some critical lessons. And one of them is this: strong health systems are the only viable path to achieving universal health coverage. And they are key to improving the health at the individual, community, and the national levels. Today's topic is pertinent, coming at a time when the resilience of the health system has been tested. It's been tested by the recent COVID-19 pandemic, a pandemic that has claimed the lives of over 3,000 Ugandans and millions around the world. But now, just as we felt ourselves emerging from the worst of that pandemic, we're finding ourselves here in Uganda being faced with another enormous public health challenge, and that is the ongoing Ebola outbreak, which I know many of you are involved in on a day-to-day basis. That's a complex challenge that poses a threat to the health of all Ugandans if we are not successful in dealing with it. And so I call upon all of us in this room to take the steps necessary to help get ahead of this outbreak, to quickly advance the response so that the experience we've had so far with Ebola is constrained, that it's prevented from expanding through other parts of the country, and we don't lose more lives to this deadly disease. And I appreciate the Ministry of Health's leadership in working with partners and others in the communities to help solve this crisis. Now, both of these health emergencies I've referenced, the COVID pandemic, the Ebola outbreak, have tested the limits of Uganda's health systems and the service delivery capacity. And when coupled with a health system that's already burdened by a high incidence of non-communicable and infectious diseases, these emergencies have placed additional strain on the system. And these emergencies have put the preparedness and the resilience of Uganda's health systems to the test as they work diligently to respond and maintain optimum service delivery. USAID and other donors have continually supported Uganda's healthcare across all these essential systems. And just one of the ways that we have done this is by actively participating in Uganda's national task forces on COVID-19 and Ebola. Times like this show just how important it is that we keep up our efforts on health promotion and disease prevention. That is what will reduce the burden on the overall health system in the long run. For this to come to reality, additional public funding must be invested in Uganda's primary healthcare system. And I'll build on my friend Moses' remarks. USAID has been working with Uganda now for 60 years in a variety of capacities. Health has been the primary focus of the last at least 25 years. And we are very pleased with the partnership that we've had, and we will continue to be a strong partner of Uganda. But in this relationship, we continually advocate for the government of Uganda to contribute more and more resources so that over time, this imbalance can switch and these health systems can become more sustainable and less dependent on partners like us and others. Even though we're happy to be here, that's not the long-term future for Uganda. Right now, according to the latest national health accounts, Uganda's yearly per capita expenditure on health is about US $37, which is far lower than the WHO recommended level for a country at this level of $86 per year. The National Health Account also reveals that about 50% of the country's health expenditures go toward curative services, and only about 20% goes toward prevention. That needs to be reversed. Government funding, thank you. Government funding must increase in order to strengthen health promotion and spur more meaningful community engagement and amplify disease prevention so that we can see more results on the preventative side, so that those 75 people who are in each health facility today are not there in the future, so that better services can be provided to the 25 that really do need those services because they're unable to be able to respond to those needs themselves. Such investment is particularly important at the district level. And I've spent a fair amount of time with district health officers and others at the other district leadership to understand their predicament. A lack of adequate funding is the primary reason why districts struggle to engage communities effectively in health promotion. There are other reasons, but lack of funding is a major reason. And that interferes with their ability to provide services and to provide oversight. Specifically, district systems, health systems, face challenges in the areas of leadership, governance, health financing, information systems, human resources, and supply chain. One recent investment that has been a success that I'd like to highlight, and it was mentioned by Dr. Richard earlier, is around the community engagement aspect of our discussions today. In this area, USAID supported the government of Uganda's vision of building a certified community health extension workforce. And so we assisted in drafting the community health workforce policy, and then helped to pilot that policy in Lira and Muyuge districts. To date, under this policy, over 300 community health extension workers, or CHUs, have been trained. In fact, just last week, there was a graduation event in Lira with the Minister of Health. These community health extension workers play a key role in connecting our communities with the healthcare facilities, which helps make the Ugandan health system more patient-centered, equitable, and functional. And we supported the rollout of this program in these 2 locations as a way to demonstrate the value of the program. Now, the impetus is upon the government of Uganda, the Ministry of Health, to carry that forward, to expand that to other areas of the country beyond just those 2 districts. We've proven that the model works. Now it just needs to be scaled up. And I hope that the government allocates resources to the Ministry of Health to be able to expand that program. In Uganda, individuals, institutions, and organizations are already promoting health in their homes, in their workplaces, in their schools, in their communities. We just need to find better ways to build off of that foundation and leverage the work that they are already doing. The current Ebola outbreak is clearly reinforcing the need to look at things differently. It shows that we must review our current health policies at all levels. We need to redefine roles and responsibilities of all players in the health promotion space. Health promotion and infection prevention and control are the key elements to stopping an Ebola outbreak. And that is where we're seeing some breakdowns still. And we and other partners and the government are working very hard to stop that, to make that better. But that is an area that's indicative of other issues with the system. It's showing that we need to be responsive in a fast-changing environment. And finally, it's showing that we need to be dynamic in our thinking and innovative in our approaches. And all of this is only possible if we have an integrated and resilient health system that's capable of responding to shocks like these disease outbreaks. So given all that we've recently faced, and given our long-standing partnerships, and given the likelihood that there will be more to face in the future, perhaps there is no better time than now to focus on strengthening systems for a resilient health promotion and disease prevention agenda, and to discuss the necessary steps to ensure universal health care access for all Ugandans. It's gratifying to see all the stakeholders that are here in this room, and I've had a chance to meet a few of you before coming in. It's my hope that the experience and the insights that you bring and which will be shared here will not just stay in this room, but that they will continue to be a catalyst for conversation, but more than conversation, to be a catalyst for action that will lead to strengthening the health service delivery and the preventative side of this health system going forward. So on behalf of the U.S. government, thank you again for all the work that you're doing. Thank you to those who have organized this conference. I look forward to hearing a lot of great discussions and some great outputs from this gathering. So best of luck in your deliberations, and thank you.
Thank you so much. Let's go for our development partner. And he's going to stay for a few more conversation. I want to invite Dr. John Baptist Wanyaye Nambohe, who is going to take lead in this session. Please note, after this session, when we have these deliberation, you shall have 3 questions, among which the questions that will be directed to, of course, Moses before he leaves. Dr. JB.
Thank you so much, our lead moderator, and thank you, the Executive Director of USAID. Already introduced John Baptist Wanyai Namboy, commonly called JB, and that is what you should call me. I am just going to take you through this session of joint discussions. And already we have had that keynote address from the Executive Director of USAID. Allow me now invite the other two participants to this discussion. Our renowned Professor Dr. Omaswa, yes, Professor, you are most welcome. Professor is the director of ArtChest. It's an NGO self-initiative, but formerly Director General of the Ministry of Health. He has been renowned internationally and here nationally. Please, let's give him a hand clap as he joins us. Then I also invite Dr. Juliet Chiguli to join us. Dr. Juliet Chiguli, she's a public health specialist and an anthropologist from Makerere Medical School, and she's from the Department of Community Health and Behavioral Sciences. She has participated in a lot of work for the last 20 years. She has been part of the COVID-19 task force, Ebola task force. She's involved in research on various issues, including lifestyle, One Health, and she sits on ethical review boards under most of the academic institutions and mainly Makerere University. Please, let's give her a hand clap as she takes her seat. I'm going to have each one give a 5-minute rejoinder to the Executive Director's address. I'll start with Professor Omaswa. Please, you are welcome to say a statement. Good, thank you.
Chair, permanent secretaries, development partners, and fellow Ugandans. I almost missed being here, but then the Lord God there had other plans and managed to cancel my other commitments to enable me to be in this meeting, which, according to me, this topic is the single most important topic that we discuss as a health sector, maybe even as a country. Moses Kamabare has said some of this, and also Richard here has made some references to this. The purpose of the health system should be to stop people from losing their health. The purpose of the health system should primarily be to keep healthy people healthy. Most of us are born healthy, and our systems biologically are very good at keeping us healthy. But for one reason or another, we focus on waiting for people to become ill and then rush around with sirens, all this. Why don't we focus on stopping them from being ill? So that's why I say this topic is by far the most important. And it is also taking place at an interesting time in the global health movement, that the call for health systems to focus more on disease prevention, health promotion, against the focus on treating those who have already been lost their health is increasing. So how then do we here in Uganda move this forward? Where do I start from? Let me start from our partners, particularly responding to Richard. First, appreciation. As you heard, I was Director General in the Ministry of Health. After the reforms, I was in fact the first Director General. I was the first chair of HIPAC. And we worked so well through the sector-wide approaches with partners, implementing one plan, one implementation mechanism, and also one monitoring. To me, when I go around the country, by the way, I'm also the current chair of the Community Engagement Subcommittee for COVID Response. So during the last 3 years, I've spent a lot of time in the districts with village COVID task forces. What I have seen in the districts is the weakening of the integration of the 3 ones. Can we, as partners, do that more? The US, even in the past, they were part of the SWAP, the sector-wide approaches, but they were not part of the direct budget support to the Treasury. But it didn't matter, as long as their resources were implementing the same one plan with the rest of the partners. So when I go to the districts, that is missing. Can we, as partners, focus on that? I also would like to Richard, you talked about, not Richard, the other, the objectives of the meeting, dialogue. How can we get this topic of ownership for health, personal responsibility for health, to become the buzz, where people are having their drinks or having their chats, they are talking about how to keep their communities healthy. And these village COVID task forces, every month I've spent a few days, 3-4 days in the districts. When villagers sit to talk about their health, they are very, very, very well informed. They talk about everything: water sources, gender-based violence, the boys who steal fruits from others, and solar panels, and there is social cohesion. Can we get dialogue to become visible on this topic in the country? And you, the third estate, is it fourth estate people, fifth estate people? Fourth, where are you in this? I would like to see our media people take a bigger role in this. Lessons learned, these things work. Community health systems work. The evidence is abundant. Why are we not doing it? And why are we not doing it? To me, the key reason is people like us. I call us techno-professionals. We know what to do. We've traveled from all over the country to come to this meeting. But then we are going back to the districts to business as usual. We have roles to do, jobs to do. Are we doing our jobs as defined in our job descriptions? If we had leaders all the way from the top down to the LC1s who were committed and care about the health of our people, we would have a different quality of health services in Uganda. The systems are there, the structures are there, but we who are responsible for implementing them can do much more than we are doing now. So I call upon us to bridge that implementation gap. And in doing that, PS, I've spoken about this before. This topic at the moment is fragmented in the headquarters. Just look at your structures there. When Dr. Kabanda talked to me about my role as chair of the Community Engagement Committee for COVID, oh, Professor, do you know that I'm the one responsible for VHTs? How can your committee work when I'm not part of it? He was right. How can we integrate this better? Just look at it, but when I see the structures, I see issues there. So those are my remarks. I summarize them by saying, let's make a buzz of this topic so that it's talked more all over the country by everybody. What to do is known, let's do it, and let's integrate, and then we who are here, let's go back to our districts and do it. And to the partners, please, let's integrate. Let's the 3 ones is the way forward. And thank you very much for your support.
Thank you so much, Prof, for a summary of what we need to do to push ourselves. And I want to say the message is clear for us to go back to the 3 ones, 1 plan, one worker plan, 1 implementation plan, and 1 monitoring plan. And for us to ensure that there is ownership and to support the community engagements at that level, and also as leaders to go back with a message that we need to change. What can I be able to do to change what is happening at the moment? Thank you so much, Prof. I ask Dr. Chiguli to give her summary. Good, thank you.
It's an honor for me to be here this morning, but also speaking after an eloquent and renowned person like Professor Omaswa gives me a challenge. I work with the School of Public Health and conducting research within the communities, but also partnering with organizations and our mother ministry, Ministry of Health, but also gender and culture, and also the ethics component. But all these ministries are coordinated by the people, and we are the people, and you are the people. So I want us to grab this opportunity and go back to what has been said in the keynote address, that health is in our hands. Health is made at home. Health is what we take, but also we are the ones who take care of ourselves before we go to meet the doctors and the health workers. So my focus is that we do have many plans, but also we must prioritize particular aspects of our plans. In terms, we've seen that we are in a hotspot area for diseases. There's been a lot of disease mapping, and these diseases are spread by our attitudes. So we need to change our behaviors. We need to focus on the way we do things. We need to focus on the way we relate to each other and relate to the ecosystem, the environment, and to the general system as well, because all this leads to cost of money. So I would like to say that we need to improve our health financing so that our budgets are increased. Our donors are here, we are glad they are here, but also we are happy each one of us does something. Contribution can be in cash, or it can also be in form of volunteership. So financing the community health workers, but we also need to move away and think about people, individuals, because diseases spread from individuals to families and then to the general community. So how do we focus on that? We need to engage each one of us so that diseases are addressed. And still going back to the issue of preventive medicine, we've seen with the case of Ebola, we've seen the case of alcohol consumption, we've seen the cases of issues of lifestyle diseases. It's what we eat, it's how we come into contact with each other. So our perceptions and attitudes must change, but still we need health financing to ensure that systems work. Because without that, all systems are connected. Without that, there is a big problem. Then the other issue is about, when we talk about engagement, engagement should begin at the household level. Professor Maswa, you've just mentioned that we have VHTs, but these VHTs are also sort of extension workers. So we are now moving to community health workers. So how can these ones be financed and using the limited resources we have? So when we are building budgets, we are talking to the Ministry of Finance. Think about that. Think about the NGO sector so that they are also able to reach out to the communities where they work. The other issue is also to think about the welfare. Generally, we tend to think that people are paid salaries, but there are those who are paid little salaries and they work overtime. So this should be really issues to be considered, because patients will go to hospitals, but then they will not get the care they want, because also the health workers, the community health workers, are not well paid. So let us think about that, but let's also think about other people whereby we engage them to be involved. For instance, we've had contact tracing. Of those who are, there's little literacy, and we have a young generation, which you've referred to as the fourth generation. They are always on social media and so on. How can we engage them that they have the right information? So we need to think about that as well and strengthen the healthcare system in terms of disease prevention and lessons to be learned. Lastly, I would say that we need to empower individuals and our communities. But how do we do that? And we need to address what are their basic needs and what are their interests. And primary health care in that way can really be addressed, because some diseases are a result of what we eat, and you get type 2 diabetes, or you get other sort of diseases. So we must engage, especially the new generation. Our generation is getting away, but the young generation is there. So those are things to really look at. Research must also be funded to ensure, and there must be connection, research done at the universities, connected to research done in schools, connected to funding up to the parliamentary level, and also collaborations. I'm here because we are partnering with the Ministry of Health in several issues like newborn health care, male engagement, and so forth. So let us go back and revise the way we think so that there are linkages across sectors. But most of all, let us appeal to those who are in management to ensure that if we draw plans, they must not remain on paper, but they must work and they must be implemented. Thank you.
Good. Thank you so much, Dr. Juliet Chiguli. It's interesting. Just to attempt a small summary there. Dr. Chiguli has emphasized that health is in our hands, and we need to do all it takes to make sure that we prevent diseases and she has made that appeal that healthcare financing, we do not need to forget the community health extension workers, and in essence, I think even the village health teams, that we need to think that right now the lifestyle diseases, we need to change our attitudes and behavior, that the real conversation on changing our lifestyle should start at household. We are so much talking about community extension, but even in the household, we can be able to change the way we look at issues. Then the issue of the young generation, that the future of health lies in the young people, and we need to engage them. And then collaboration, research, so that we utilize the research which is generated in the academic institutions to policy and to implementation. So thank you so much, Dr. Juliet. Let's give a hand clap to the team. We are now going into the question time, but I will invite Dr. Moses Kamabale to join so that we can receive some questions at the same. It will be short because of time. I will allow, of course, questions will go to the discussants. The keynote, usually we don't have questions for that. 3 questions. I will have one for Professor Maswa, one for Dr. Chiguli, and one for Dr. Moses Kamawale. Please, it is open. Good. That's the team. There is a hand here, please. 1, 2. Where the microphones? I don't have the names, but please. You are not following my hand. The first is here, please. The first is here.
Thank you very much, the moderator. My name is Dr. Christine Nabidio, and I work with PATH. We've all heard this saying, and I'll say it in the way it is said. Government etuyambe. Government etuyambe to mean, can the government help us? Then here, I also heard the other that we normally say, abagabiba sente batuyambe, meaning let the donors help us. And I'd like to thank the panel because you've all touched on an important aspect of the responsibility that is invested in the individual. Thank you for honoring us as the individual. Thank you for honoring the Ugandan as responsible for their health. And I would like to turn it out and say that under the HIV movement, we had prevention starts with me. And now as we go into the global health challenges and primary health care, I'd like to say, let's borrow from what worked in the past. Primary health care should start with me. And therefore, when we say that we are here, we are in this conference, and we are going back wherever we are coming from, I'd like to challenge each one of us. As a Ugandan, you hail from a village. You hail from a family. You hail from that grandmother and grandfather that have made you who you are. Can we go back and hold the hands of the community and move forward. Like, I don't remember who said, was it Moses Kamabare or was it the professor? And meet them halfway, meet the donors, meet the government halfway. Can we play our part? Meet the partners halfway. Primary health care starts with me. I remain Dr. Christine.
Thank you, Dr. Christine. And there has been a comment, and
I hail from Gomba district. Jumbi is my village. And if you go to Jumbi, they'll tell you about me.
Thank you, Dr. Navirio Christine. Let's have, I apologize, I have not marked the names and positions.
Yeah, thank you very much. My name is Aseko Abdul Mutwalib. I am the district chairperson of Yumbe district. I want to thank the convener for this very important conference. From the presentation of Dr. Kamabare, there's been the concern of supplies against demand, and specific to districts that are hosting refugees. I want to bring this clearly to the conference, that as leaders on ground, we have always had a challenge of not factoring in, when we are planning at national level, the refugees within the districts that do host these refugees. And therefore, when it comes to supplies from national medical stores, the consumptions are extremely higher as compared to the population. So my appeal, as we discuss here about issues of prevention, is that we must equally look at the consideration for the refugees that we do host. Like Yumbe is one of those districts hosting the highest number of refugees, of about 246,000. And therefore, when it comes to some of these interventions, in most cases, we have a challenge. Right now on ground, there's the indoor residual spraying that's going on within West Nile, and Yumbe district is one of those districts benefiting. But yesterday, we had a district task force for this particular intervention. One of the issues that was raised by UNHCR and IRC, which is our implementing partner for health, is that when planning was done at national level, there was no consideration for the refugee population. So I want to request that Minister of Health, I'm happy that PS is here, and the commissioners, this should be given due consideration.
Noted. Yes.
Lastly, there's been a serious mention about male involvement in the issues of family planning. I want to hope that we will not only be restricting ourselves to family planning, because men in African settings are the heads of families, and therefore they influence decisions in families, and therefore in all the health interventions, be it malaria, be it cancer, and the rest of the diseases, I think men must play a very critical role. And therefore, we need not restrict this to only family planning. Men must be involved in all the healthcare services at household level. I beg to submit.
Thank you so much. This side now, I want a question this side, and we finish. That is Dr. Nzubo.
Thank you, moderator and presenters. Onzubo Paul is my name, DHO Maracha. I picked one phrase that community health systems work, and I have added they should be made to work. And it is only our responsibility to make them work. We saw this actually in several districts where I've worked. We pushed plague to the corner, now reported at the death of rats. that is in the Zumbu district. We pushed away cholera. That was a biannual issue in a rural municipality, now turned into city. It worked. In Maracha, in the COVID period, as people were struggling with the institutional quarantine, we only had 14 out of 153 cases. That was our cumulative number. And the majority of these were managed at home, except 13 cases, among whom 3 died. Those are the ones but it was about the LC1, the VHT, and the community members. So ladies and gentlemen, the community health systems work. My only appeal is to the decision makers at the national level. We are doing a restructuring. And I have seen in the new structure, instead of building on how we can reach the community with the adequate health education, we are putting doctors at Health Center 3. I don't know what they are going to do. Kindly, if you can listen to us, kindly remove that from the structure and instead convert that to health educators and environmental health staff. The decision we take now should be in line with the parish development model. Actually, as a Minister of Health, we already moved to village level. That's why we have the VHTs there. So we cannot do that. The doctors will be redundant. The second thing is, severally DHOs and the DHT members have been looked at as evils. We are actually the drivers of community health and health made at home. We are gatekeepers. We reduce the number of people who would actually consume Kamabare's medicine. Thank you very much, my brother.
Thank you. Thank you, Dr. Ozubo. We have had you clear. I think there is an online audience. You will allow me, if there is a question online, that will be the fourth, then the panelists can respond. No one online? The Secretariat, is there any question online? No? Okay, Madam PS.
I want to thank the presenters, and I am just responding to what my colleague suggested. The purpose why we decided to include a doctor at Health Center 3, first of all, we want to reduce the doctor-patient ratio. You know that is a very serious indicator, and there's no way we can just keep people at the top. And I want to tell you that even at Health Center 3, there are patients that will work in Health Center 3 that require a doctor. And so why deny them that opportunity? Secondly, putting a doctor at Health Center 3 does not stop us from also strengthening the capacity and the numbers of the health educators in the districts, in the facilities, and at the lower levels. I also want to clarify that the current structure, if it was really performing, if we were doing our work as we should be, if, for example, the health educators were really on ground doing their work as they should be, we would be seeing more effort, more resilience, more output. It is because I remember and recently I was talking to some colleagues and I was like, but when I was growing up, I would see people come home, inspect our homes. If anybody in the village did not have a latrine, my goodness, they would fine you. You would even go to prison for that. If you did not have basic primary health care, whatever systems at home. Now, why are we not doing this? Is it because the doctors are there? No, it's because people are not doing their work. It is because we have abdicated our duties to whom it may concern. Even the people who have been recruited and paid a salary to do this work, to go down and really articulate these issues at household levels, are not doing it. And therefore, putting doctors at Health Center 3 will definitely give opportunity. Even the doctors, for us when we are being taught, I studied from Barra University, and one of the modules that we had to undergo was to go in the community and get to know the real problems of the communities, so that when the patient comes to me in a hospital, I'm able to treat, but at the same time, I'm supposed to provide guidance on how to prevent, not just treating, but also giving information so that you prevent the infection, you prevent the reoccurrence, because you don't want to just be on the receiving end, but you are supposed to also be there. You treat, but at the same time, make sure that you provide information that will prevent. So it is not a threat, it is not a problem to have a doctor at Health Center 3. We are trying to make it very, very intentional, that even doctors have a role to play to talk about prevention, to talk about disease prevention at facility, but also at the same time in the community. For us, we used to go to the community. So, therefore, as I conclude, the doctors are necessary at lower units because, number one, it is noble that we reduce patient population ratio. Number two, we must also ensure that the doctors put in place a mechanism, not just treating, but also feel it is their responsibility to talk about and educate the population on disease prevention. Number three, we make sure that also the people who come to Health Center 3 and require the doctor's input and treatment are also taken care of. Thank you very much.
Good. Thank you so much. Give a hand clap to the PS again, because PS has explained it, but the issue even arose from you people before it reached the PS's desk. The issue of the need for us to have a community responsive doctor, it arose from those requests. That is why it came up the policy level. But that is something which I think we shall discuss more. PS, when we call these DHOs and the municipal health officers, I think we shall be able to have more dialogue on that matter. But it is something which is required. And the other countries have even what they call the foot doctors. I was reading about the China and the other country story. I'm doing badly in time, so I will allow our panelists to respond. I'll start with the professor, then Dr. Juliet, then end with Mr. Kamabali. Thank you. Come in, Prof.
Well, friends, it's been a good discussion. And my general response is this one. Like our friend from Maracha said, we know what to do. Community health systems work. Why don't we implement this? And implement one village health committees. We created them for COVID, but in our recommendation to the parish development model people, we suggest that these village COVID task forces be converted into village health committees. under the parish development model, so that every village has got people, the VHTs, who reach every household. The PS is talking about reaching households. We have village health registers, which when the VHT comes to my house, the head of this home is Omaswa. His wife is so and so. Is Omaswa okay? He's got sugar. That's what they call diabetes or blood pressure. And his wife is pregnant. Is she going to deliver where? The children. So these structures already exist here in Uganda. Why don't we implement them to the full? So DHOs, chairpersons of districts, mayors, these structures you already have. Why are we not implementing them? Then development partners, let's work with these people in the districts, with your resources, so that we implement one integrated district health plan, not fragmented district health plans. We can do this. And then at the headquarters, PS and your colleagues, I talked about how you can look at how you can make your support supervision more streamlined to the districts. Make sure that you visit all these districts regularly, monitor what they are doing, rank them, reward those who are doing well, support those who are not doing well. Uganda, let me tell you, my friends, has got one of the best structured health systems in Africa. Let's just make it work. But to make it work is about you and me, each of us committing ourselves like you join a religion. Kamabare, you're talking about gospel according to what? They started with 12 people, but look at how many these people are. If each of them decided to join that religion, Uganda would be a different place. So let's go and do it. Thank you.
Thank you so much, Prof. Let me have Dr. Juliet.
Thank you once again, Moderator, Mr. Moderator. I think what has clearly come out, also I will refer to what Professor Maswa said and the PS. I think when I was growing up, my mother was a social worker. So these things of public health, before I went to the School of Public Health, they are very clear to me. Then at the same time, I remembered that hand washing was crucial. I mean, we were taught in school, in nursery schools, but those who never had the opportunity as well to go to nursery schools were able also to learn from their homes. So I think a child in Africa is brought up by a whole village. Let us be the ones who are doing neighborhood watch so that we prevent these diseases. But also, I would like to emphasize that there is only one doctor to 10,000 people. When I was growing up, the population was 12 million. Our children are growing up, we are over 45 million. So how can those resources which we have be able to meet the health requirements of such a big population? So let us go back also to the role of fathers. They used to be the ones providing, but nowadays also women are empowered and they are providing for their homes. Let us put our resources together. Let us budget. Let us have some money aside, saved. Even if you are earning 10,000, save some of that money so that you can be able to meet your health costs. And also going back to engaging the communities have structures. Let us use those structures so that health is addressed. There are so many social network groups which we can look at. Let us have those models included into the parish model so that there are system linkages everywhere. Then lastly, the educators. I've seen a friend go out to Arua, the West Nile districts, and there used to be rats, which are edible rats, which are being eaten. But then how were those affecting the granaries? Someone has mentioned one of the district officials from Yumbe. And they found out that the only way we can reduce the cost, which Ministry of Health is budgeting for in terms of addressing plague, is that we can make sure that people know how to relate to what they eat. So let us remove barriers and create enablers in terms of managing our health. Thank you.
Thank you so much, Dr. Judy. Dr. Moses?
We have heard before that people don't do what you expect. They do what you inspect. How is the structure in the health system organized in such a way that they inspect what they expect? If we are agreeing here that we change the model, or at least we start moving towards the health promotion and disease prevention, how are we changing our systems in such a way that that is what the Ministry of Health would inspect? When they are rewarding the districts for their performance, they are not rewarding them against other indicators, but the indicators they point at are those that will be leaning towards health promotion and disease prevention. We've had before people, why would you want to give a health facility more budget? Because what they are presenting are the number of people they are treating. They should be punishing them for that. The moment you reward that kind of tendency, we are treating more people, therefore give us more money. Those are the people that should be sacked. Those are the people. So if we build it within our systems, it is very easy to follow through. So we request our supervisors in the Ministry of Health and the people gathered here, how would we put a checklist that will actually punish the people who bring and attend to the more patients that come to us rather than the ones that keep them where they are supposed to be, make sure that they stay where they're supposed to be healthy. So the gospel, as Professor has said again, and I've said it earlier, the gospel according to Saint Prevention should be the gospel that we should spread here. It is, have you heard it? Have you understood it? Do you believe it? And can you act on it? Huba should be the word. So not Uber, it is Huba. Have you heard the gospel? Have you understood the gospel? Do you believe it? And can you act on it by talking to, if you've heard it, if you understand it, if you believe it, talk to somebody about it, and let's do something about it. I think it will work for us. Thank you.
Thank you. The audience is saying that this is now Pastor Kamawale. Let's give a hand clap. Members, it's a very interesting discussion. I wish we had more time, but I know you have picked most of the suggestions, the way forward from our experts. I want us all together to give them a warm hand clap and thank them for the time they have given us. Thank you so much. This session comes to the end. Thank you. Good. I request you can.
Let's clap for the first session. A round of applause again, ladies and gentlemen. It's been very, please. It's been very engaging. I love the conversation that is on the Zoom link and on Twitter. And because of time, I love accountability. I come from the fourth estate. Maybe for Dr. Julie, she was alluding to Generation Z, the Z generation. That was, she was alluding to that. From the fourth estate, we love accountability. Let me see my person with the red flags here. Okay, please stand up so that people can see you. This lady here is going to be our timekeeper. So to the next speakers, when you see her raising that, all of us will be in position to see. We get to know that time is done. So when she raises the yellow, you have 5 minutes to wrap it up. The red one comes in, it's time up. I wanted us all to understand this because Dr. Kamabari said the traffic officer should be inclusive. This is inclusion, Dr. Kamabari. Thank you so much. You can take your seat. Allow me to welcome Dr. Patrick Tumusiime, the Commissioner National Disease Control, to take up the next session, which is going to take us towards lunchtime. Let's welcome Dr. Patrick Tumusiime.
Thank you, Chair Magero. Ladies and gentlemen, distinguished participants in all your capacities, you are very welcome to this next session where we are going to look at putting people at the center for sustainable health promotion and disease prevention. I'm Patrick Tumusiime, not Tumusiime, Tumusiime, from the Ministry of Health, and I'll be chairing this session. We shall be having a keynote speech by Dr. Munir. He's around in the room. Thank you for coming, Dr. Munir. And then thereafter, we shall have experience sharing by people at the front line who are coordinating all these responses. And there will be Dr. Ochen Patrick, the District Health Officer from Rira District Local Government. Health officer, not medical officer. Health meaning a holistic approach that involves medical care and disease prevention. Emmanuel Kayongo, Senior Advisor, Social Behavior Change, and Bonena Nkunda, the District Senior Health Educator, Wakiso District Local Government. So as we prepare for this, join me to welcome Dr. Munir, the country representative for UNICEF, to give us the keynote address. You're welcome, Dr. Munir.
The Honorable Permanent Secretary of the Ministry of Health, the convener of the conference, my young friend, Dr. Kabanda, ladies and gentlemen, all protocol observed. A very good afternoon to all of you, and it's a great pleasure for me to join you today for the second conference on health promotion and disease prevention. Let me start by sharing a few thoughts with regard to the topic we are addressing under this session. And the topic is quite thought-provoking. It's about putting people at the center of for sustainable health and promotion, putting people at the center for sustainable health, promotion, and disease prevention. And let me start by saying that it is my strong belief that our health as human beings is determined mainly by our lifestyles. And our lifestyles are determined by a number of factors, some of them, most important of them, our own behaviors, our own attitudes, our own high-level goals of what we want to achieve in life. And the quality of information available to us and the way we are trained to process this information is at the center of our behaviors, our attitudes, and the way we manage our lifestyle and we manage our health. I therefore believe naturally when we talk about health promotion, disease prevention, people are at the center. We don't need to put them at the center. They are already at the center because health is lifestyle, it's who we are. Then the question, where is the problem? The problem is that often health planners, decision makers, they overlook the fact that health promotion, disease prevention is about people, and that people are at the center or are the center of the processes. So we need to find ways of reorienting ourselves as health planners, as decision makers, to sustain, maintain people as the center of health promotion and disease prevention. Thank you. And here I would like to offer a few sort of thoughts, ideas of how do we do that. And I think many of what I'm going to mention has already been mentioned by earlier speakers and colleagues who made very valuable intervention. I think the most important thing is the following consideration, that we have to avoid top-down approaches by health professionals and decision makers. No top-down approaches. We cannot dictate new behaviors and new lifestyles on people. We can't. What we can is to engage with people and persuade them to adopt healthy lifestyles, healthy, positive attitudes for their own interest, for their own good health. We need a bottom-up approach, an approach that starts by a dialogue at the community, rather than someone deciding what the community should be doing and imposing that on them. The second important consideration, in my view, is to acknowledge that health promotion and disease prevention are about promoting a respectful dialogue between two equals. And by the two equals, I mean the health professionals and the community members. We need a respectful dialogue, a dialogue between two equals. The health professionals must strive to understand the social, political, and economic factors that shape people's minds and lifestyles. When decision makers use the power of the state to regulate the lives of communities, people know how to fight back. And they know and they succeed in undermining any regulations that they don't believe in. Allow me here just to pause for a couple of seconds and share with you very recent examples of how this is happening, how people can undermine regulations that they don't believe in. They don't feel they were part of their making. The fact that a few people in some of the Ebola-struck districts took the decision to exhume dead bodies and re-prepare them and re-bury them in their own way is an example that we missed something very important. We missed engaging these people. And it is very interesting because when we had a few weeks back a regional meeting for health ministers in this exact room here, the Minister of Health from Senegal, he said it's important to work with people specifically on procedures and processes related to safe and dignified burial. And he shared with us the experience from Senegal and how it transformed the process in something that the communities believed in, accepted, and practiced. It's one example that we need to adopt here. Another example is the fact that at the moment, so many people who are contacts of positive Ebola cases have gone under the ground. Simply, they have no belief that the institutional isolation or quarantine is good for them, is good for their loved ones in their households, and is good for the communities. It's an example, in my view, of not to follow a top-down approach, but engage people in making these important decisions. Let me move now to, in my view, an important third consideration for putting people at the center of health promotion and disease prevention. That is about resource allocation. Resource allocation should reflect the decision that we want to prevent diseases. We want to promote good health rather than we want to promote curative health. As my friend Richard Nelson, the director of the USAID, mentioned, in Uganda, 20% of the budget is allocated to prevention. This has to be reversed. If we don't reverse this, the number of people who will continue to require curative health care will continue to grow to the extent that at one point they will overwhelm this health system in the country. I'm concerned with the fact, and I'm happy the PSU are here, that when I read the first budget regulation, I saw something, and I hope it has been corrected in subsequent versions of the budget for 2023-2024, that the budget allocation for 117 districts were scheduled to be reduced in a significant way. If we reduce the budget allocation for primary health care, for community health workers, we will not support prevention. And there will be always a gap between the talk and the walk, and we need to reverse this. I have had the opportunity to interact with so many village health team members, VHT members, amazing people who are volunteering their time to work. But they often complain about the lack of basic enablers for them to do their job effectively. Some of them, they say distances that they have to travel are far, and they need bicycles, not a motorbike, not a car, bicycles to reach the communities that they are supposed to cover. Some of them, they said, we need stationery, a notebook and a pencil to write down the conversation, the comments we have from the household visits. These are very basic things, but when we do not allocate reasonable, adequate resources for these community health workers, for these village health teams, then we are not walking the talk. We need to fix this. I'm very happy that this is the second conference discussing the same topic and engaging more people from Uganda and from outside Uganda. It shows, in my view, the seriousness that you in the Ministry of Health and all the development partners, civil society organizations, the health professionals and the health practitioners, the seriousness with which you are addressing the issue of putting people at the center of health promotion and disease prevention, which translate into primary health care in my view. I'm very much delighted again to be here, and I would like to thank you, Dr. Kabanda, and the organizers for giving me the opportunity to be with you today and to share these few thoughts I have already shared with you. Thank you very much.
Thank you, Dr. Munir. He has really brought the message out clearly. Just in a few words, our health is determined by our lifestyles. Before we even go to the people, to bring them in the center, me and you, are we healthy? Put a torch inside your own life. Are you healthy? If you are going to reach out to others, are you giving them what you have? Avoid top-down approaches. As we put our people at the center of health care, that is a very good message, that we should avoid top-down. These people know a lot, actually, and we need to understand them, find them where they are, and see what they believe in, what are their values and preferences, what is their need. So as we come to them, let's not think we know it all, because at the end of the day, they must appreciate the issue at hand and be able to take action. And taking our people as equals, when we go to them with that attitude. You are negotiating with somebody who is equal to you regarding matters of their health. Don't think you know it better than them. And resource allocation, walk the talk. Thank you, Dr. Munir, for these insights. And give him you clap if you want to clap. Aha, thank you. Now, it sets the ball rolling. Now to listen to our commanders at the front line, the people who are leading teams in the communities. We are going to listen to them, and I will invite, as I had told you earlier, Dr. Ochen Patrick Chan, DHO leader. Please come and share with us your thoughts. Not more than 10 minutes.
Yeah, thank you, moderator, our permanent secretary, Minister of Health, all dignitaries from development partners, and the team from the ministry, all invited guests, ladies and gentlemen, good afternoon. I have already been introduced. I'm Dr. Ochen Patrick Buchan. I'm the District Health Officer, Lira, and I'm here to give a brief testimony of health promotion initiatives at the district level, especially with regard to Lira district local government. It is true, yes, that if it is about health promotion and putting people at the center, it's not all about use of natural resources or the resources that we have. And it goes beyond that to encompass the use of people, and especially dealing with the ultimate individual, to exert influence over the determinants of his or her own health. And in Lira district, we have had this work for some time, but from 2014, health promotion initiatives became more pronounced. And as district leaders, we actually drew a lot of lessons. This was a time when actually we enrolled community-based activities, including indoor residual spraying, mass drug administration, because Lira is one of the districts which is worst hit with malaria, but also we have neglected tropical diseases. And at that time, we actually began by educating the communities about health promotion and letting them to know what diseases were of a burden, and encouraging them to take drugs, especially when we had a lot of lymphatic filariasis, we had a lot of trachoma. But initially, we thought it was going to be an easy walk. Not until when we learned our own lesson that yes, it was a good initiative, but unfortunately the community that we were dealing with was not enlightened. I remember at that time when we were doing mass drug administration, the ministry had done a very good thing by, at the central level, demonstrating how to take it and using key leaders when actually they were launching. But at the district level, when we used the district leaders without penetrating deep in the villages, there were resistances until the district chairperson had to come loudly on air and then also take the drugs, because there were a lot of myths and misconception. At that time, we realized that yes, if you want community health initiatives to actually yield good outputs, you must begin with the ultimate individual at the grassroots, especially the local leaders, because their voices sound louder than the voices of the health professionals even at that level, including even the national level. And so we realigned our strategies as Lira District from then up to now by ensuring that whenever we have any intervention, health promotion initiative, we begin at the grassroots as it was being said. Because when we don't begin with from the grassroots, there is always resistance. And so at our levels, I want to thank Minister of Health that yes, we have a very able village health team. They have been facilitated, even if they are volunteers, when there are initiatives like mass campaigns, we always get support from the Minister of Health and we facilitate them, and it motivates them to carry on. But one thing we have learned is that whenever something good takes place, especially when the results have been registered, even the village health teams that we are using get motivated with only results when we share with them the findings, what we have done. So each time we carry out a community health initiative, we give feedback reports to them, and then they get to know how they performed, and how each village performed. And that way, it has made them actually to move together with us and to support us in community health initiative. Number two, we also realize that even the ultimate individuals take messages differently. And there are a number of factors. The poverty level is one of them, but of course, the worst is the ignorance. And so people of low socioeconomic status tend to have higher burden of diseases, but unfortunately, they are less willing to take up key messages compared to other counterparts who are well-to-do. But the worst is people of low educational status. They tend to be slow at taking up messages when we are having community health initiatives than other counterparts. And so in our community engagements, we always map out those areas which are, we call them in quotes, difficult villages. And what we do is to ensure that we penetrate more to them. And when we are on radio talk shows, we ensure that the messages that we give reflect the challenges that we encountered in those villages and how to mitigate them. That way, it has made many of them to come along. And from 2014, when we introduced IRS, it is true that the initial rollout was not very easy because there were a lot of resistances. But also we realized if you want to reach a bigger mass, you can use other structures like the religious group. Their voices are really very strong because each message that you give them, once they take it positively, the religious leaders, when they are with their congregation, they can make the message penetrate faster. And they're a key resource. And from that time up to now, we have always made sure that each time we have engagements, a new program coming, we must make sure we bring the religious leaders and the cultural leaders on board. And they are our key people when they want to reach down to the villages and to the communities. We also realize that, yes, the local council structures that have been established are very important because they are leaders at that level and they deliberate upon their functions within their localities. And each time they do so, they want to actually earn credit because in the subsequent elections, they want to get back to their seats. And so we also use that as an opportunity to harness support from them and use them for passing key messages. I remember lately when we had the COVID-19 outbreak, Lira was one of the districts which was worst hit because it is a corridor where truck drivers pass from. And so we engaged all the religious leaders, all the LC1 chairpersons, and all other key resource persons, and we equipped them with knowledge about COVID-19 spread and how it can be prevented. Trust me, when the vaccines were coming and we heard about myths and misconception and resistance from other districts, in Lira the resistance was very minimal. I want to report that I think Lira was one of the best districts in the country that achieved the highest coverage of COVID-19 vaccination, just because we use the structures effectively. One thing also we have realized that yes, there is no one-size-fits-all approach when it comes to health promotion and disease prevention. Different communities need to be reached differently with key messages, but one thing is that you must be part of them if you really want your message to sink. Meaning that your engagements must be more frequent than ever if it is a difficult community than other communities which are easy. And so from time to time we map out those difficult communities and reach them out frequently than others, and that is why we succeed in our community interventions. We want to thank Minister of Health when actually we used to receive Uganda Sanitation Fund for supporting villages to be open defecation free. And Lira is one of the districts that benefited, and we reduced the prevalence and the incidences of intestinal worms in the district greatly. Why? Because many of those villages that we triggered and declared open defecation free, we used not only the VHTs, but the local persons, the key resource persons, the model homes. We would use them and they would move to other places, and we pay exchange visits amongst them. So you're a worst village performer, you move to a village which is performing very well, and when you come back, you have some challenges that you have, you have some tasks that you must come and perform, and that is how we actually improved greatly sanitation in those areas. And one thing that I must mention is that yes, if you want to make sure that your program is sustainable, engage the ultimate individual. Make sure that that person owns the program. And that person will only own the program when that person is knowledgeable about it and that person has been empowered to support the program. I want also to report that yes, while we are doing this, there are a number of challenges that we are registering. While in 2019 we agreed that yes, districts must commit 20% of our PHC to supporting health promotion and disease prevention strategies, we still have challenges because of the same amount of money that is being sent to districts, especially at the district health office, to support that. And it is actually constraining us not to effectively implement our commitment of 2019 when we had the first conference here. But also logistical support. We have health assistants, and I'm happy to report that in Lira district and Lira city, all the units have health assistants, and they're a good resource in championing health promotion and disease prevention initiatives. Unfortunately, many of them lack transport means, and maybe our dear peers, this is a very key message. Sometimes you find them struggling to reach a place, and when they are caught up by rain, you find them coming back, giving you a report, but unfortunately, they keep also bringing back that issue of lack of transport. Indeed, we realize that they need to be supported in terms of transport so that they can reach every corner. And the last thing I must say is that yes, as Lira district, we want to thank Minister of Health for extending aspect of health promotion and disease prevention. I understand there are a number of offices that have been established. The district system is robust enough because our senior health educators are a key resource for being the heads of health promotion and disease prevention at the district, and they roll this down out. Thank you very much for listening to me.
Dr. Chen has put it very clearly, and thank you for those insights. Specifically, he has stressed the issue of involvement of people's leaders. People elect their leaders right from the village up to the district, up to parliament. So these are people's representatives. And if you are reaching to the people with the health message, prevent diseases, and promote good health involve the leaders, including religious leaders. He has also stressed the issue of the non-medical determinants of health. And that is where the catchword is. We get out of the cycle of thinking that we can fix health by treating diseases. We get out, and knowing that the other stakeholders actually play a bigger role. The medical component of health is just like 10–15%. The other 85% are the other determinants he has mentioned: education, addressing poverty issues, agriculture. We need to open our minds and get out of this cycle where, since time immemorial, everybody equates health with medical treatment of diseases, and has ended with ownership of these interventions by focusing on the people we are putting at the center. Thank you very much, Dr. Chen, for those insights. And now I will call the other two discussants to come and join us here. And I will reduce their time to 5 minutes. So, Dr. Mr. Kayongo and Bone kindly join us here, and I'll invite Emmanuel Kayongo to share with us his insights. You can feel free to sit in your chair and share with us. If you want, you can come here, whatever is comfortable for you. Feel free. I have started counting.
Thank you, Doctor. The Permanent Secretary, Minister of Health, the Minister of Health top management officials, implementing partners in the House, district officials, invited guests, ladies and gentlemen. My name is Bonena Tukunda. I'm the Senior Health Educator for Wakiso. I'm here to share experiences on how we can put people at the center and how Wakiso has been working in putting people at the center as far as health promotion is concerned. First of all, I want to start by appreciating Ministry of Health for having thought of putting a certain fee for health promotion to ensure that at least health promotion activities are not left behind. Now, as Wakiso District, there are quite a number of interventions that we've conducted when it comes to health promotion. One is community dialogues. We've been having so many community dialogues, and part of those community dialogues have been part of the health promotion fund that comes to the districts. What we do as Wakiso, we have about 71 government facilities. So basically what we do, when these funds come, each facility gets facilitation, and we ensure that part of that money is used to conduct community dialogues. So we map especially the places where there is a lot of resistance, and we move to those different health sub-districts to find out what are the challenges. The health-seeking behavior, we try to see how best we can improve the services depending on what is happening, especially in communities where there is a lot of resistance. I also want to take this opportunity once again to thank Ministry of Health for having supported us to have the village health teams. In Wakiso, we have about 2,880 village health teams, and these village health team members have been at the forefront in all interventions that we conduct. So every time we have an activity, we ensure that these people are trained first. By the time they move to the communities, they actually know what they are supposed to do. I want to give an example, like in this outbreak of Ebola. Already we've invited these VHTs, we've trained them, and they know what to do. They are already on the ground, and they are also passing on the same information to the communities as far as Ebola and other health interventions are concerned. I will also not deviate from what my colleague has just said. Wakiso also, we've been using a lot of consultations, because we all know that with health promotion, it is basically empowering people. So when you think you're going to come as somebody from up, when you've not consulted people, you lose it all. So what we've been doing basically, we've been consulting different stakeholders. Every time we have an activity, we call the different stakeholders for meetings. Cultural leaders have been part of the people that we've been engaging. The religious leaders also have been part of our teams. I also want to say something. Wakiso, I think, has got the most complicated, I must say, political part if you do not invite them, if you do not involve them. But I want to say that with involvement of the political leaders, health promotion has been brought at the forefront. Every time we have an intervention, we ensure that the councillors are part of us. We ensure that the LC5s are part of us. So all that has helped us to make sure that health promotion moves in front. Also, we've tried to ensure that integration of health services, as you've heard, 71 facilities are quite many.
Ladies and gentlemen, allow me to welcome our guest of honor who happens to be here. Let's stand up and welcome the Minister of Health. I beg to interrupt this presentation briefly. You're welcome so much, Honorable Minister of Health. And now that she's here, let's have the national anthem sounded. The East African anthem. You're welcome, Honorable Minister. Ladies and gentlemen, you can resume your seats, please.
Thank you so much. Also, at the same time, as Wakiso District, we've been conducting a lot of health education and information sharing. In this regard, we basically conduct health education in the different villages, at the different media stations, and for us this time in Wakiso, we do not just do health education like you go to a village and you do health education at once. Basically what we do, we try to do a lot of segmentation so that we say if today we are going to meet this category of people, you meet these people differently because what you're going to tell the youth, for example, is very different from what you're telling the mothers, is different from what you're telling the children. So we try to do segmentation and ensure that the right people are getting the right messages without just mixing up the different messages. Also, we've tried to use the champions. As you may all know that when you use the champions, people have been at the forefront, people have been involved in activities, people tend to listen more. For example, the youth, every time we go out to the community to conduct health education, if we are targeting the adolescents, we ensure part of our activities, we involve the youth to also help us do health education. In that regard, you find that the people you're passing on the information to, they are able to take it up better, rather than if at all with the health workers, who are the only ones at the forefront. I also want to end by saying that, yes, we are doing a lot of health promotion. However, there's quite a number of challenges, if I'm to mention one. And one of them is the behavior change, as everybody may know, is a gradual process. Sometimes when interventions are new, you find that, yes, you're telling the people, but it takes them time to change. However, for us as health educators, we always we don't give up, because we believe that as time goes, people tend to change. Also, the myth and misconceptions, especially the new interventions, but we also tend to continue. We conduct constant sensitizations to ensure that at the end of it all, at least people are able to take up the intervention. Thank you so much. I remain Bonne Natukunda, Senior Health Educator, Wakiso.
Thank you, Bonnie, and immediately I will invite Emmanuel to share with us, but in a shorter time, if you can summarize in 4 minutes, so that we are able to catch up with time. Thank you.
Thank you. I'm Emmanuel Kayongo. I work for a USAID mechanism called the USAID Social Behavior Change Activity. We support the Ministry of Health to identify barriers to behavior change around a number of health issues. And we use the latest research and science to design interventions that can help cause change at population level. And like the project goes, we get our funding from USAID. So today's topic, or the topic we're meant to discuss, putting people at the center of sustainable health promotion and disease prevention. In my work, we tell a lot of stories to get people to change. So I have 4 stories to tell. The first story, many of you, I'm sure, use Ginger Road when you're coming to this place. And you pass Nakawa. Now at Nakawa, there's a flyover where people are meant to, it's a flyover, but also it's a bridge flyover, where people are supposed to cross the road. Okay, which people are supposed to use crossing the road. But in the morning, as I'm sure many of you came, many people were running. So the question is, the director from National Medical Stores was asking, who are we talking to? So the guys who designed that bridge, did they talk to the people? Did they involve them? Food for thought. The other one that I see on a daily in my work, when you go to Karamoja, we gave nets, we gave out mosquito nets. The type of structure of the house, a lot of the time, doesn't actually allow for the net that we give. So again, whereas we have ensured they have the right knowledge, they have accepted the net, but they just can't use these nets. Food for thought. Again, another story from Karamoja. When we were doing work there last year, we interacted with the communities. And they told us that the problems we see, we are partly to blame. They told us that in the past, when people like us went to the villages, they actually gave us a goat, gave us a cow, or chicken to come with. But because of our approach, we have actually made these people weak, because now they wait to receive things from us, rather than them finding solutions. Then the other one that is big in terms of health promotion, these issues that we tackle, Ebola, malaria, HIV, or family planning, like everyone has been saying, who is the owner of this problem? Is it us, or is it the people? Who is most affected by them? Is it us, or is it the people? Now, Dr. Twine talked about the doctors doing health education. Do they listen to us as a community? Are they empathetic? Are they caring? Do we trust them? So these are the issues that we deal with on a day-to-day basis before we can convince people to take up these things or the practices we're asking them to do. The last story, in 2014, I worked on another USAID project called Communication for Health Communities Project. And the challenge then was to design interventions that are attractive to the people. When we did research, people told us, like Dr. Munil said, you people talk down on us, you don't listen to us, you think you know it all. So as we're doing the research in the communities, we fell on something that was very critical, that changed our minds. So in many places of this country, when you go to a home and ask how people are, people will tell you their life. Again, two stories to this. So if you go to Kaliro, for example, and you ask the man, how are you? That man will tell you about his chicken that died yesterday. They'll tell you how they didn't feed. They'll tell you how maybe the wife has gone for a burial somewhere. Now, by just asking that simple question, how are you, they tell you their lives. And therefore, they're telling you how to approach them. But a lot of the time, when you go to these people, we go to tell them information, what to do, without necessarily finding out what is the context of their lives. Again, another story. For this one, I must confess, I'm also Catholic. So, for family planning, a lot of the time, the biggest challenge is said to be with the Catholics. So if you go to a Catholic's home and say, I'm here to talk about family planning, a lot of the time they will chase you. Or they will not be receptive. But if you went to these homes and asked them, how are you? They'll tell you about how the children didn't feed. They'll tell you about how they're struggling with school fees. Now, those are entries to talking to these people. That's what defines putting people at the center of health promotion and it being sustainable, because you're working within their contexts that affect them, but also affect the decisions you're going to ask them to do. So the biggest experience in terms of health promotion I've encountered, and I've proudly been part of, is behind there, is what we call Obulamu. So Obulamu is an integrated campaign that the Ministry of Health led in developing and we all supported, which is about working within people's contexts. So for example, if you go to talk to young people, what matters to them? For example, for Obulamu, we used to say, how is your love life? Because at that point, love is what matters to them. If you go to a pregnant woman and you don't ask them, how is the pregnancy? They will not pay attention to you. But when you ask those questions, or when you go to an adolescent and don't speak their language, or for example, you don't use WhatsApp, they will never understand what you're saying. So the best example I have in terms of putting people at the center is that integrated campaign. And like I've explained, like Dr. Munil said, one size doesn't fit all. So from those interventions that we've been doing with the ministry, one size doesn't fit all. We try to ensure that every audience has something to pick, or we're targeting them. Then I'm about to finish. Then the other one is ensuring that we are honest in the way we listen, we're empathetic. So we use a lot of audience feedback in the work that we've been doing. And for some of them, for example, for COVID, when there were issues to do with mobilizing people, when we use these approaches, especially in the districts that we had, we saw that people quickly lined up because we're listening to them and we're integrating our messaging or our approaches into what they like to listen. And then the last one is a supportive environment. When you get the leaders, if the leaders don't change to stop being top down, then it becomes hard, because at the end of the day, the people want to listen to their leaders. So if the leaders sort of follow the same approach we are taking, what we have seen is that people easily adopt these behaviors that we're talking about. Ladies and gentlemen, those are my experiences. Thank you.
Thank you, Emmanuel. Allow me to take this opportunity to thank all the discussants. Your insights into this topic were very enriching. But my apologies, we are not going to the question and answer time because we are time bad. But if you have a burning question, kindly note it down and pass it on so that later we can see how to fit it in and answer it. I want to thank you all panelists. Thank you. God bless you all.
Ladies and gentlemen, let's clap for that panelist again. That panel was super exciting, super engaging. It was very humbling to hear thoughts from the USAID and to hear from a health worker who comes from my district, Wakiso. So some of you who stay in Nigeria, you think you're you're in Wakiso. So she was speaking for all of you. Some of you think Wakiso is Pastinansana, Nigeria, Wakiso. Okay? Ladies and gentlemen, I want to give you confidence that we are going to have, there is a session we skipped earlier on where we had the keynote address. This is coming in from the Chief of African Region, Dr. Mogala, who will actually be presenting this after lunch now that the minister is here. And I want to give you confidence that the Honorable Minister is here with us to the end of this occasion. Let's clap for that, ladies and gentlemen. That means a lot to us who are in health. And at that juncture, allow me, Honorable Minister, to give you a wrap-up of what happened in the morning. But before that, with us, we have some political leaders. We have the LOC5 of Bukoma and Simbi. Mr. Nyenje Fred Kayira is here with us. And we have the Mayor of Masaka City, Honorable Namaya Anja Florence. She's equally here with us. In the morning, Honorable Minister, we had a very clear conversation where we listened to the chairperson of the organizing committee about the agenda and the objectives of this conference. In the same way, we heard from Dr. Richard Kabanda, the Commissioner of Health Promotion, Education and Communication, about the progress as per the previous resolution in 2019 vis-a-vis today. We had a very good one. This came in from, it came from Dr. Moses Kamabali, the cost implication of delivery of curative services, perspectives from the national medical stores. Just so you know, Honorable Minister, we had a clear lashing as the fourth estate when it gets to curating these conversations to the last mile in the country. In the same way, we had and listened to a panel that was discussing strengthening systems for resilient health promotion and disease prevention agenda. While you came through, we were still dealing with putting people at the core of sustainable health promotion and disease prevention. Friends, after lunch, we're equally going to have more conversations about the operationalization of community health workers in Uganda, and we shall have a conversation on understanding the community health extension workers. And with that, we have the pilot of the Uganda Insights from the baseline survey. And we shall have the keynote address as well as the address from the PS, Dr. Atwine. And we shall have a message from the chief guest, who is the Minister of Health. And later we shall launch the occasion of we will launch the key national health promotion strategies and plans. Now that we are going for lunch, I'm a Christian. I want to suggest that please move with your valuables. I know you came with very many laptops. In the morning, I saw a couple of you in Zoom meetings and your phones. The Bible says that when the children of God convened, The believers, you know how that goes? So we come from different walks of life. We come from different districts. You can look at your neighbor, tell your neighbor, I trust you. But please carry your variables as we are going for lunch. Okay? So in the next sessions, ladies and gentlemen, let me welcome my colleague here, Midwell Tohai. So let's clap for her as she comes here. Let's clap for her. She's from NBS. I'm from NTV. This is the collaboration we are going to be having time and again, leave alone what happens on Twitter. This is how we collaborate. Dr. Moses Kamabali, this is how we work together. So Mildred Rice, let's clap for her again. She will be taking us in the next session. That will be after lunch. And she will be the moderator for the next session. As NTV and NBS, we believe in shared responsibility at the core. Friends, she will speak when her time comes, but I had to bring her here that you see her.
Okay,
Yes. No, wait, we shall live together. We are going for lunch. Lunch is going to be on the other side. There's some particular tents where we are going to go. Please, while you're there, make sure that you do it in a snappy way. We have 1 hour for lunch. Actually, it is, let us meet again at exactly 2:20 p.m. Thank you. Okay, let's use 30 minutes. Let's use 30 minutes. You are youthful. Cindy, let's use 30 minutes and we come back for the next session. In a special way, I want to recognize the presence of Asiku Abdallah Mutalib, the LOC 5 of Yumbe District. Where's the LOC 5? He's here. Thank you so much, sir, for gracing this occasion. Friends, let's break for lunch. Please carry your valuables to your way to lunch. Thank you.
We'll give them about 2-3 minutes. Just invite back your neighbor and make sure that we all get settled. For those who are outside and you can be able to hear us, please, let's make our way, because in the next 3 minutes, we will be starting off our afternoon session, which is going to, of course, take into consideration the opening ceremony, which we didn't have earlier on in the morning. And then also we will go into our breakout sessions at a later stage. But please feel free to join whichever breakout session of your choice, because tomorrow, before we start the second day, we'll have a little bit of a recap, because we're going to have rapporteurs in those sessions. We'll have a recap of what would have been discussed. So I know that you may feel pained attending one and missing out some information from the other, but that will be sorted. So it's just 3 minutes, and we will be starting off with our afternoon session. So let's get everyone in. Whoever is still outside, let's get back and get settled. All right, ladies and gentlemen, our chief guest is back, and at this, we are ready to start off. Once again, good afternoon, but just before we continue, I am kindly requesting any team members from BRAC Uganda, the chairperson who is right at my extreme right, right there is in need of you. So if you are a team from BRAC Uganda, please make your way to the Chairperson Organizing Committee because there is some message for you. Ladies and gentlemen, welcome back from lunch. My name is Mildred Tuhaise, and I'm glad to be hosting this particular afternoon. This is not just because I am someone who works with media, but health is key to me. Having grown up in a family of very many health specialists, I think I normally say I had to be the one who deviated because the whole family could not get into health entirely. A daughter of a nurse with so many sisters and relatives in the health sector, I know how important health is, not only for the sector in itself, but also the well-being of the country, for economic development. That is why there is the saying that a healthy nation is a wealthy nation. You cannot talk about wealth before you talk about health. And public health is central because whereas we know that there is consideration of private sector health service provision, but if you're thinking about the last mile person, if you're thinking about the average Ugandan, the one we call Omuntu wa wansi, definitely you're going to think about public health and how we can better public health, and not always asking what government has done, but also asking yourself, what can I do to help change the situation in public health that we are looking at? And that is why this conference is very, very key, especially looking at our theme, which is strengthening primary health care through sustainable health promotion and disease prevention approaches. Like they always say, prevention is better than cure. You don't want to be looking at how to treat a disease when it's already there, but just how much more can we be able to prevent. When you look at non-communicable diseases, many of them can easily be prevented. But probably because there's not been a lot of attention in sensitization on how those diseases can be prevented, that is why we are burdened as the public health sector in having to release budgets for diseases that we could have actually dealt with before. If you look at sanitation-related diseases like cholera, I mean, it's just about the lifestyle that you can be able to prevent those. So it's very timely to be looking at such a discussion. Like I said, in this session, we are going to pay attention to our key opening ceremony, which we didn't get earlier on, and then we will move out to our breakout sessions, which will be looking at various discussions. But ladies and gentlemen, we know that we pay attention to sustainable development goals, United Nations being partners, and one of the key aspects is leaving no one behind. And we cannot be discussing health when we can't include everyone. And so, ladies and gentlemen, I would like you to invite with me Claire Tumusime, who is going to be our sign language interpreter for the next session, so that our friends who use sign language can also be able to partake of the discussions and information. And to the Permanent Secretary and to you, Minister, I want to say a special thank you to Ministry of Health, because I don't think I've attended any Ministry of Health discussion or conference and it has no sign language interpreter. That means we're not leaving anyone behind, and I think we should give a round of applause for that. Everyone is included. Ladies and gentlemen, for our next session, which is also going to include the keynote address, allow me invite the Director General of Health Services at the Ministry of Health. That is none other than Dr. Henry G. Mwebesa, who is going to be taking on this session. And our keynote address is going to specifically focus on strengthening primary health care through sustainable health promotion and disease prevention approaches, just as our theme does state. So with a round of applause, ladies and gentlemen, let's welcome Dr. Henry G. Mwebesa to take up this session. And as he comes, I want to specially recognize the leaders from Masaka City. The Chief Administrative Officer of Masaka City, Mr. Kaweya, is here. The chairperson, Mr. Luchamuzi, please, if you just stand up and wave to us, and the town clerk, Mr. Abraham Tebi, as well. So the entire administration is here of Masaka City. Dr. Mwebesa, over to you.
Thank you very much, Mildred. So we are going to the official opening ceremony. First of all, I want to thank the team that has organized this meeting, because we are supposed to have had this in the morning. But they reorganized the program, continued with the sessions, and rescheduled this. So that was very good, and I really want to applaud them. So allow me to invite the following who will be participating in the official opening ceremony. Please join me to welcome Dr. Kabanda Richard, the conference convener. May I invite you, Dr. Kabanda, to join us here. Allow me to invite the keynote speaker, who also is going to join us, Dr. Natalia Mogala. I'll be introducing her in detail later. You're welcome, Madam. You can take the first seat there. I think you can come here. All the piece. Allow me to invite the Permanent Secretary, Ministry of Health, Dr. Diana Twine, who will be part of this opening ceremony. Okay. Good. Ladies and gentlemen, join me to welcome the Honorable Minister of Health, Dr. Jane Rosa Cheng, to join the podium. So these will be my guests for the opening ceremony, which I'm pleased to chair. You are all welcome. Of course, we have lost quite some time, but as I said, I want to thank the organizers. They managed to catch up with time by substituting other programs. So we'll go straight to our presenters without wasting a lot of time. At this juncture, allow me to invite Dr. Kabanda Richard to tell us why this conference. I'm aware you already gave us the objectives of this meeting earlier in the meeting, but for purposes of this opening ceremony, Dr. Kabanda, please, you have the floor. You'll tell us why we are here, what we need to know, and how long this conference is going to last.
Thank you, DG. Our guest of honor, the Honorable Minister of Health, the PS, our keynote speaker, the Director General, directors, commissioners from the ministry, our political leaders from different districts, the RDCs who are here, the chief administrative officers, our senior colleagues from the districts, the development partners who are here, the implementing partners, the media, ladies and gentlemen. Good afternoon. Honorable Minister, I know this week is very busy. We would have had you here for the full 2 days, just like it was in 2019, when the idea came up of having national conferences on health promotion and prevention. I remember very well the support we got from senior top management on the need to prioritize this area, given the fact, as I said earlier on, that the diseases we have in the country, over 75% of them are preventable. it is true and a fact that prioritization still goes towards curative. I know the minister and the PS have consistently, despite the fact that they are clinicians, they have consistently drummed up the need to focus on promotive and preventive health care. So we are here. This is our second conference. The first one was in 2019, which you honored. We are here to take stock of progress of the key resolutions that we took in our first conference. And I did read out the key resolutions and the progress we have made and the support you have provided in ensuring that some of these key resolutions are implemented. One of them was the development of the harmonized comprehensive health sector communication strategy. You remember very well we received resources from UNICEF, but it was out of the will of senior top to ensure that these resources were available to us. And this strategy was presented to top management, which you chaired. It was approved, and we have developed a number of copies for all participants here. So we are using this platform as one of the avenues to disseminate some of these key documents. The other key document which we have also printed out, which you are going to launch still after your official speech, is the National Community Health Education Handbook. This handbook summarizes a number of diseases and conditions that are common in the country, and we have simplified messages which can be used by our community health workers, but of course also other health professionals as they engage with the communities through different avenues. That time, we are also tasked to ensure that we respond to issues that promote health of women, and that way, there are two key documents which we are also presented to top management and they were approved. One of them is the advocacy strategy for promotion of family planning in the country. So we have also printed a number of copies, and all participants here have these copies. We still have some copies. We have disseminated some to the districts. We are also going to disseminate more of these copies out. The other one is the operational plan for promotion of antenatal care services in the country. This operational plan was also approved, and we hope that in this engagement, we should be able also to have the document launched. The other key document, Honorable Minister, not document, but an innovation. We were tasked that time that every time our colleagues from districts and implementing partners ask for key health promotion materials, they are able to reach out to us directly, which is tedious. We take a lot of time and all that. So with the support from USAID, we have been able to develop the Uganda Campus for Health Promotion, which will enable people be able to access health information online. All the promotional materials that we develop and approve as the sector, they will be virtually available for use. People don't need to come to the ministry, or they don't need to seek approval from us. Once they access the platform, they are able to look through which kind of materials are available, and we shall keep on updating. That will include IEC materials of any nature, all the videos that we develop, all key documents, strategies, plans, and all that, guidelines, they will also be accessible to this platform. We shall also be able to disseminate research that has been conducted by different key stakeholders, research skewed towards health promotion and prevention, to ensure that practitioners and academicians can be able to refer to that kind of work. Honorable Minister, this engagement, we also use it as an advocacy tool to continue to drum the need to prioritize this key pillar, because we know that it is the way to go. We also hope that we shall be able to share key undertakings that have been accomplished since 2019, like the recent pilot study, of which you participated and the PS participated in passing out the trainees. So we are also glad that we are going to have a presentation on the baseline study that has been conducted, so that we have also practical discussions with some of the key players to enable the larger group here to be able to pick some of the key issues and get updates. The other key issue, we also expect to get some key insights from policymakers, planners, and implementers on some of the key issues the Ministry of Health should focus on within this key area of health promotion and prevention as one of the ways we can strengthen primary health care service delivery in the country. Of course, one of the key things we expect for you to honor is to launch the developed strategies and operational plans that have been approved by the sector to enable our implementers be able to implement better when they are well guided. Lastly, we hope that we are going to engage with the policymakers. We have a session with them that has been financed or supported by PATH tomorrow, which we hope that the PS will be able to chair in the morning from 9 to midday. And the essence of that engagement is to ensure that we interface with the policy makers. We expect over 30 members of parliament who sit on the health committee. And the expectation is that we are already in the budgeting cycle. We have started. We don't want them to keep asking the Ministry of Health questions. They have a role to play. We should be asking them questions and want them to ensure that the component of primary health care is looked into keenly, more so within this space. As I conclude, Honorable Minister, allow me thank the partners whom we have worked closely with to ensure that we have this kind of arrangement. I remember your words in 2019. We had a very good conference that time, and you did task us. You were asking yourself whether we would maintain the standards. And one of the reasons why we never wanted to have conferences every year is to ensure that we commit some issue, some things, we give ourselves time to address them so that by the time we get back here, we are able to report on some of the key issues. But of course also, we know that if we have this as biennial, we shall be able to have our partners be able to engage this from a more informed point of view. The organizing committee whom we have worked so closely with, I must say thank you very much. This is day one. We are here till tomorrow. We hope that by the end of day two, we shall definitely have we shall have had a very successful conference. DG, that's all what I have as a preamble. We thank you, Honorable, for coming, for gracing, and hope that we should be able to have you here till the end of this day. Thank you very much.
Thank you very much, Richard. He has highlighted the objectives of this meeting. He has also given a very good accountability of his outputs, which the minister will be launching and commissioning today. But also, he has highlighted to us the outputs of this meeting. Thank you very much, Richard. And without wasting time, I'll move on to the next presenter. There will be a change of protocol a bit. The PS is going to close another meeting. You know, we are multitasking. There are so many activities going on. Ideally, the PS would be coming later to invite the minister. But because she has to go and to open another meeting, I do now want to invite her to come and make her remarks, and thereafter we shall have our keynote address. Please join me to welcome the PS, Minister of Health, Dr. Diana Atwine. Dr. Diana Atwine doesn't need introduction, so I will save time on that one.
Honorable Minister of Health, our chief guest or the main speaker of the day, our country representative of Perth, the country, our senior officials from the Ministry of Health, the district leadership representing the entire fraternity of the local government, the implementing partners, friends, ladies and gentlemen, allow me in the interest of time just to summarize my remarks in just 4 points. First of all, I want to thank you so much for organizing this meeting, and I do believe that if we make this more regular and that this message is continuously talked about, you continue drumming this support, we shall get more people on board, especially the leadership in the districts and our main community leaders. We'll be able to change the shift of approach to diseases from curative only to mainly focusing on prevention. Because as you heard, first of all, I want to thank the presenters this morning. I think they elaborately put the message very clear to us. I want to thank the Mr. Kamabari. This morning, pushed it right in our heads. Honorable Minister, while you are away, Mr. Kamabari said that the districts that are performing so well, reporting many cases of diseases in the district should be sacked. Because their main purpose, their main objective is to make sure that we have as less people sick in the community. So really, even if we don't take any other message today, we need to look to focus on how do we assess the performance of health sector in the district. Is it the number of people sick coming to our facilities, or the more healthy the population, the more, the better is our performance. So it was very well elaborated. So I was just giving you that information because you missed it. The second thing I just wanted to mention is that health promotion and disease prevention is everyone's responsibility. It is not a responsibility of Ministry of Health and local government, implementing partners. It is everyone's responsibility. If we can make this message to every person in this country who has understanding, not children, not the insane, but the people who actually understand. If we can get this message appreciated by everyone, I think this is something that we can leverage on, and people start taking this responsibility in their hands and make sure they actually. I think it was Dr. Christine who said, "Government etuyambe." This syndrome of government etuyambe. You fall sick, children get diarrhea at home. You don't make an effort. Government etuyambe. You get ruptured uterus because you delayed to come to the hospital. Government etuyambe. You don't attend antenatal, services. You don't, take care of your children at home. You don't get children immunized. Government etuyambe. So that syndrome also, we need to deal with it. So it is everyone's responsibility. Number two, it is high time we have integrated approach. Integrated approach is more productive. It leverages on little resources that we have because we don't have sufficient resources. If someone is going to talk about malaria in the community, why also not talk about immunization? if you're at household talking about hygiene, why also not talk about immunization? That's why we came up with the handbook that our community members, when they go to the community and they are asked, they can refer to that. Every information is in that handbook. So integration of our approach so that the TB person comes, talks, then leaves, then defecation free, you know, we have those ones. They come also, talk, then they leave, then you have, you know, so that they don't get the whole comprehensive message. So we need really to see at community level how we can integrate these messages. Thank you very much. You can clap. It's not only... The third thing is that the structure at grassroots is sufficient actually to deliver this strategy that we have to make sure that we reduce disease burdens in our community. We have a laboratory, I think someone here, someone mentioned it here. We have a elaborate structure up to the village. If we leverage on it and we make it a targeted performance, a sub-county chief, what is your target as far as disease prevention is concerned? The LC1 in your village, what are your targets as a leader of this village as far as disease prevention is concerned? The village health team, what have you targeted in your village to achieve? So that then once we have that targeted approach and defining the roles and know that I am a village health team, this village must have 100% open free defecation, something. Herbert, I'm talking your language. So if we are able really to target, give targets. And Professor Maswa this morning, I think, talked about how do we integrate, and actually we can even use parish development model, even to report the targets at that level. Lastly, although we do not have sufficient resources, because resources will never be enough, as a country, we are still growing, our resource envelope is not sufficient. I was amazed, Honorable Minister, when I sat here, then everyone said, now PS has come. It is good also PS is seated here. Now it is good PS. They forget that we only use resources that we have been provided. So if the resource envelope is small, I will not perform miracles. I'm not God. So, Honorable Minister, I hope in your communication you'll help me to save my neck, because it's like, I am here and things are going to be now resolved. It cannot be resolved because we do not have sufficient resources. But one thing I know and I am convinced about is that much as we do not have enough resources, the human resource is the most important resource in this country. The human resource with the right mindset, with a targeted performance, with clear-headed objectives, and the right strategy at the community, we can change things even with the limited resources that we have. Thank you, Christine. Thank you. No amount of money will change things on ground if I eat meat and whatever I throw kavera, whatever I throw things all over the place, it will not change. The drainage will block, the sewage will, everything will be wrong because the mindset is not right. So, the most important thing right now we need to As we talk about human resource, I mean resources. I heard. I was here, Honorable. When I came, they were like, she has come. It is not about just resources will never be enough. But what are we doing in our roles, in our areas of jurisdiction, in our influence, sphere of influence? What are we doing? First of all, to share the information so that everyone around us understands that this is a core objective for our health sector. Then how do we now implement it? How do we make it implemented at the village level, at the household? How do we make these mothers appreciate the nutritional status of our children? That is the most important, even that they will not fall sick, not only going to the facilities, but also they get better even in school, they'll perform better. How do we link the performance and the well-being to the practice at household level? How do we link the economic empowerment and economic development of a country with a disease burden reduction? So that even an economist who is talking about GDP and capita income per capita is linking the well-being, the well-being and the health at household. So that way, if everyone is speaking the same language, we'll be able to tackle this problem and we'll be able to successfully deliver health and we'll be able to achieve the universal health coverage that we have all signed up to achieve in the targeted time. Thank you very much. My Honorable Minister has allowed me to go, but I wish you great stay and deliberation. We shall be able to join you also tomorrow. Thank you very much.
Thank you very much, Madam PS, for emphasizing the importance of health promotion and disease prevention, and in particular integration of our messages and even integration of our interventions. I'm happy you emphasized the importance of human resource in all this, and in particular emphasizing that increasing the money will not improve services unless we improve our mindset. So, since you already have the permission to go, we can allow you to go. As a chair, I can give you the director to escort you. Chawa Yinza, you have the pleasure of escorting the PS to go. Maybe she'll pass you a voucher tomorrow. Honorable Minister, before I invite our keynote speaker, there have been some of our district leaders who have been introduced, but a few have not been introduced. But we shall continue to introduce them. Allow me to introduce Mr. Asiku Abdul Mutalib, LC5 Chairperson, Yumbe. You are welcome, sir. Madam Namayanja Florence, Mayor Masaka. I think she had been introduced. You are welcome, Madam. Mr. Nyenje Fred Kayira, Bukomansimbi District Chairperson. Welcome, sir. Batemie Tolchamuzi Andrew, Chairman, Masaka District. You are welcome, sir. We have RDCs, but I have only one name here. Please, may I have the list of RDCs? Madam Phoebe Namlindwa, RDC Kasanda. She's the lady who has been fighting Ebola in Kasanda, and she's almost chasing it out of Kasanda. Where is Phoebe? Oh, she's there. She needs a big clap, please. That lady is battling Ebola like no man's business. Other diseases? Okay. We have cows, the Bukomansimbi Chief Administrative Officer, Mr. Peter Ruhweza Nsungwa. You are welcome, sir. And David Kawoya for Masaka Chief Administrative Officer. You are also welcome, sir. But I'm informed there are other RDCs. Please, let's receive their names so that we can introduce them at an appropriate time. Honorable Minister, allow me now to invite our keynote speaker, Madam Dr. Natali Mugala. Dr. Mugala is a chief of party of PATH for Africa region. She is a pediatrician by profession with over 25 years experience, leading and heading various health programs in Zambia and even across the continent. She has flown in all the way from Lusaka, and we really appreciate, and she deserves a very big clap for that, even before her presentation. She's going to present on a topic, strengthening primary health care services through sustainable health promotion and disease prevention approaches. You have the floor, Madam. Thank you very much.
Thank you very much. Greetings, everyone. Chief Guest, Minister of Health, Honorable Dr. Jane Ruth Acheng Ochero. May I simply ride on the protocols earlier advanced? It's wonderful to be back in Uganda, the Pearl of Africa. I was here in June with our PATH president, Mr. Nikolai Gilbert, who actually sends his greetings. We actually paid the courtesy call at the Ministry of Health and met with our dear Permanent Secretary, Dr. Diana Twine. And it is really truly an honor to be invited back to this beautiful country full of wonderful people. And I would like to thank the Ministry of Health for giving me the opportunity to deliver this keynote address at such an important public health forum. My thanks go to the organizers and everyone who helped to make this event a success. I hope I can get this right. How do I change the slides?
IT, the slides are not moving.
Which one?
IT team, help us, please. Seems a problem of the remote. There is the remote.
Okay, there we are. Yes, okay. So this is my presentation outline, and I'll skip that and go straight to the next slide. As you are aware, the conference theme is strengthening primary health care through sustainable health promotion and disease prevention approaches, which is also what I will be discussing, looking at a broader public health perspective and reflecting on recent situations as well as my own perspective. So I get the privilege to give my own perspective as a keynote speaker, and also sharing examples from past work in Uganda, the Africa region, and globally. I did share with you the outline of my presentation. Allow me very briefly to talk about PATH, the organization that I work for. We are a global organization dedicated to ending health equity. At the core, we believe that better health moves humanity forward. When people are healthy, they can work, they can go to school and focus on the future and build better, more prosperous lives. I think this has been alluded to several times in this forum already. And this is why we at PATH actually focus on the world's most pressing health challenges. We are a global team of more than 1,500 people at work in more than 70 countries, especially in Africa and Asia. And in our work, we actually partner across ministries, governments, and the private sector to develop and roll out life-saving vaccines, create affordable diagnostic tools, and scale our impact through advocacy and policy efforts. Our mission at PATH is advancing health equity through innovation and partnerships. Now, I have taken a little bit of time to talk about PATH because the theme of this conference is actually at the heart of what we do, and remarkably close to my heart too, because in the end, everything we're talking about is about equity. There is no reason that the best technologies and health tools should be out of the reach from people simply because of where they are born or currently reside. Whether you are in Kampala, Gulu, Mbarara, or in any country in the continent, one should have access to life-saving tools, products, and commitment, and commodities. For PATH's work in Africa, so for the Africa region, PATH is using the continent's internal and our global expertise to drive transformative and innovative practices that work in the African context. We thank the government of Uganda and our partners here for the past 2 decades, and believe it, PATH has actually been working in Uganda for the past 2 decades. PATH has been honored to partner with public and private sector to introduce tools and interventions that prevent and detect cancer, expand women's contraceptive choices, get vaccines to more people, and craft policies that lay the foundation for health for every Ugandan. With your support, together, we have implemented high-impact projects to address Uganda's health priorities and are improving health equity while playing a substantial role in the nation's efforts to address emerging health threats. So with that, ladies and gentlemen, what is primary health care? Since the 1978 Declaration of Alma Ata, WHO has promoted primary health care as a core component of health systems. It is rooted in a commitment to social justice, equity, solidarity, and participation. It is based on the recognition that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction. For universal health coverage to be truly universal, a shift is needed from health systems designed around diseases and institutions towards health systems that are designed for people, with people, and that is a goal of primary health care. Primary health care is the most inclusive, equitable, cost-effective, and efficient approach to enhance people's physical and mental health, as well as social well-being. Investments in primary health care improve equity and access, healthcare performance, accountability of health systems, and indeed, health outcomes. Now, in alignment, before we actually reflect on how to make primary health care more resilient, which is really the cornerstone of what we're talking about today. As a pediatrician, I couldn't resist, but I wanted to mention 2 of the most critical preventive and promotive approaches that have been at the core of my professional career. One is vaccinations and immunization. It is a well-known fact that vaccines and immunization remain the most effective means of preventing infectious diseases. So you can see the statistics that we have there on this particular slide. But here we are today, after all the successes we have had since the invention of the first vaccine against smallpox by Edward Jenner. I hope we all remember our history. In 1796, this important public tool is being threatened. Why do I say so? We are losing ground in vaccinations. For example, we are witnessing outbreaks of polio cases in countries where the disease had previously been eradicated, as well as gaps in vaccine coverages for diseases such as COVID-19. And really, ladies and gentlemen, this is a stellar example of where significant investment is required. On the promotive side, our dear old breastfeeding. We know the importance of breastfeeding as a promotive intervention. Yet, according to the UN, fewer than half of all newborns are breastfed in the first hour of life, leaving them more vulnerable to disease and death. And only 44% of infants who are exclusively breastfed in the first 6 months of life, only about 44% of infants are exclusively breastfed in the first 6 months of life, which is really short of the WHO the WHO World Health Assembly's target of 50% by 2025. During emergencies, including those around the Great Lakes, like in Ethiopia and the Horn of Africa, and the vast Sahel region, breastfeeding guarantees a safe, nutritious, and accessible food for babies and young children. Honorable Minister, ladies and gentlemen, how can we make primary health care better and more resilient? Let us invest more resources to primary health care today to make systems more efficient in health promotion and disease prevention. We need to adopt a people-centered approach to primary health care, and I think this has been echoed by a lot of colleagues that have presented before me. Let us co-create with the people. This again was overemphasized this morning. Study when, where, and how people need and want to use primary health care. It's extremely important. As we invest in information systems, we must also invest in the human resources needed to turn this information into better clinical and management decisions. The consequences, unfortunately, ladies and gentlemen, of suboptimal investing in primary health care are severe. The Ebola crisis, plummeting vaccination rates, and the measles outbreak, as well as wide-ranging disruption to essential health services, are all consequences of suboptimal investment in primary health care. If we build strong health systems that are grounded in people-centered primary health care, we are going to be able to withstand the disruptions we have seen in the recent and ongoing emergencies. Strengthening systems for a resilient health promotion and disease prevention agenda is extremely critical. So, ladies and gentlemen, when we speak about health systems, let us remember that it is all about the people. And by definition, a health system is all the activities whose primary purpose is to promote, restore, and maintain health. It is important that we note what we mean by a functional health system. Reflecting on building partnerships and expanding networks for holistic health promotions. The health problems, ladies and gentlemen, that we face today will be solved not by governments. I think we heard this very clearly from the Permanent Secretary a few minutes ago. Will be solved not by governments alone, but in partnerships. Partnerships with philanthropy, global businesses, and civil societies. Through partnerships, ladies and gentlemen, we know that we can encourage visible and sustained political support. We help to develop nationally negotiated joint plans of action, increase financial resources, and strengthen national and regional technical capacity. This, I'm sure you agree with me, ladies and gentlemen, that makes a lot of sense, and we will see the benefits of partnerships. So the slide there really talks about why it's important that we have these partnerships, as I mentioned. And the next slide there just amplifies why partnerships are critical in all phases of research or product development, or indeed system strengthening processes. Now, another element that is important in primary health care is a people-centered primary health care. We did, I think, again, a lot was talked about why it's important to have a people-centered approach. I will emphasize this point. People are central and primary to everything that we do. Broadening civic engagement and amplifying citizen voice are critical in translating primary health care commitments into programs that align with community needs. Individuals, ladies and gentlemen, Honorable Minister, are the experts of their own needs. We heard this over and over again, both as consumers and increasingly as providers through self-care and caregiving. We know of interventions where individuals actually take control of their own health. For instance, when we are looking at even family planning, and we have self-injection commodities. By underscoring the connections between individual experiences and larger primary healthcare systems, communities can mobilize to demand and to co-create accessible, high-quality primary health care. Integrated person-centered care. Again, we did hear the Permanent Secretary talk about the issue of integration. So integrated person-centered care means putting people and communities, not diseases, at the center of the health systems. It means making multiple services available in one place so that care is easier for the people to access. This way, we will be able to deliver an organized health system that better meets people's needs. So it is important that we just, don't ask what services are provided or delivered, but we also look at how these services are actually provided and delivered. So just because multiple services are offered does not necessarily mean that they will be accessible at all. It is important that we note that. So the way that they're delivered is actually extremely important. So integrating services at the point of care is a proven way to improve both access and outcomes. Again, this was touched on by the Permanent Secretary, really important. When we look at, again, how services are delivered, I did allude to this. So we should not just ask what services are delivered, but it's important to look at how are they delivered, in what format, in a vertical format, in an integrated format, and I think we are all aligned that it's important that services are delivered in an integrated format. Now, coming to strategic health communication for early detection of diseases and really drawing lessons from the HIV response. So again, when we look at communication as it relates to strategic communication and how this actually informs or guides early detection of diseases and also prevention of diseases. So again, whether in a consultation between a nurse and a patient, a health clinic director's engagement with the health ministry, or a community campaign for encouraging or sharing surveillance data, strategic communication is key in tying the various pieces of our health systems together. I'm going to share a few examples to illustrate this point. So firstly, I will share an example from Uganda. Adapting health communications to our advocacy tactics, which happened during COVID-19. In 2021, PATH partnered with the Kampala Capital City Authority to promote good practices around COVID-19. As part of these efforts, local policymakers leveraged national media outlets to bring effective public health messaging directly to the communities. In June 2021, PATH and KCCA planned media engagements at NTV and NBS, where experts discussed COVID-19 public safety and risk information, prevention strategies and treatment options for those infected with COVID-19. This work covered a broad range of areas: maternal and child health, routine immunization, and gender-based violence during the epidemic, airing more than 84 times throughout the year. We also worked to educate members of the media on COVID-19 and essential health services by hosting media trainings and briefings. Again, learning from the HIV response, communication when done properly can motivate people to adopt positive health behavior, to go to the clinic earlier, to get tested, obtain their results, promote access to treatment, link people living with HIV to care, support retention in care, and help reduce stigma, which is extremely important. Failure to communicate the right message effectively can result in loss of trust, damage to the economy, and loss of lives. What have we learned from the HIV pandemic? The early years of HIV/AIDS pandemic were plagued by confusion, fear, isolation, and discrimination. And I'm sure you all agree with me that we've come really far. Today, it threatens progress in combating COVID-19. Finally, ladies and gentlemen, let us not wait to spend more money to treat the sick. I think this has been alluded to again over and over again, which is more expensive. Let us spend more time keeping more people healthy by investing in health promotion and disease prevention. The problems we face today will be solved not by governments alone, as I said, but in partnerships with many other stakeholders. And we must work together. As you know, I'm not sure if Uganda is familiar with this famous African proverb which says, if you want to go fast, go alone. If you want to go far, let's go together. So partnerships are really critical. And also because collaboration or partnerships allows us to know and to do more than what we are capable of doing by ourselves. In conclusion, ladies and gentlemen, primary health care is a whole of society approach that my conclusion slide is refusing. Oops. Never mind. Oh dear. Anyway. So in conclusion, ladies and gentlemen, primary health care is a whole society approach that aims at ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs as early as possible along the continuum of care, for health promotion and disease prevention to treatment, rehabilitation, and palliative care, as close as is feasible to people's everyday environment. This cannot be achieved without focused and sustained health promotion and preventive approaches. Ladies and gentlemen, I thank you so much for listening to me, and may God bless us all. Thank you.
I think I have to stand up now. Another very, very big clap for Madame Nathalie. May I also request for a very big clap for Claire. Claire Tumusime is my daughter here who is doing all the interpretation. We can entertain maximum of two questions. I know usually people who deliver keynote addresses are cushioned from questions, but I think Madame has allowed to receive at least not more than 3 questions, if they are there. But it looked all very clear, and I will not be surprised if there's no question. Good. That is the consensus. It seems it was very, very clear, Madame Nathalie. Big clap for. There's one? Okay.
Thank you so much. Of course, we have agreed that we're all going from curative to preventive. And we are also looking at inclusive or inclusion. Now, of course, as we implement these things, we also have to look at the systems that we are using. If you have a preventive approach now, you have health workers, you have DHOs. To me, I think if you have a DHO, why should one of the qualifications be somebody who have done medicine? Why don't we also include some people who have done like nursing, but maybe have the background of the masters in public health, be included so that they can also spearhead the implementation of these things? Because now we are living the other side of curative, we are going to medicine. I have a background in public health at diploma. Apparently I'm doing masters, rather at bachelor's, I'm doing masters in public health. Why should I be having medicine as a background to be a DHO?
Thank you very much.
Can't I implement preventive medicine? Thank you.
Thank you very much. Introduce yourself, sir.
I am called Governor Joseph, a student of public health, masters, Mbara University of Science and Technology.
Thank you very much. I think that's not a question for the keynote speaker. Maybe the minister will talk about it in her opening remarks. Yes, sir. Minister, you captured that. I will remind you. Yes, sir. Introduce yourself. And be brief, please.
Yes, sir. I have two engagements. First, on the challenges.
Introduce yourself, sir.
I am the chairperson of Masaka District.
Okay.
But I'm told Charles Andrew. Take an example of Masaka District. We have got a challenge of standby provisions for preservation of vaccines. We have ordinary free refrigerators. Can you imagine? Most of the vaccines just go to waste within no time. We don't have any solar standby. We don't have any standby generator. And this one is even widespread in Masaka. Secondly, you were talking about research. The traditional herbalists, like the Dr. Nambatia, like the Rashidi Lukwago. Why are you not working hand in hand with these people? They are doing a lot to the population, but you just go to Makerere University, just go where? But they are helping us down. Thank you very much.
Thank you very much. Again, that's not a question for the keynote speaker. That's a question for Minister of Health. I'm closing now. Yes, sir. Because the questions are coming to Minister of Health.
Yeah, Asiko Abdul Mtwalib, District Chairperson Yumbe. The keynote speaker mentioned the activities that have been undertaken by PATH in Kampala. And Uganda has 146 districts and cities. I want to hope that after interventions in Kampala, PATH should be able to roll its activities to other districts.
Yumbe, that's the only question you have, Madam Natali. I think let me close questions there, but I can answer one question, the question on fridges. The program, the UNEP program, has tried to replace most of the fridges. The gas fridges, I think we are doing away with gas fridges, and we are doing away with the fridges which are run by umeme. Most of our fridges are run by solar now. By solar. I know there is a project called Solar Now. By solar. So if in Masaka we still have a problem, we shall come and handle that with the district. The Director of Public Health is here, he has heard, because I think that should by now be history. Let's handle it after that. Then the other question, we're working very closely with traditional healers. I think we are working very, very closely with the traditional healers, and we even have a law to that effect. But I also wanted to comment on one thing which the keynote speaker talked about, which was the issue of, I wrote it here, strategic early communication for early detection of diseases. I understand we have DHOs here, we have DHEs here. I hope you noted that very seriously. Early detection of diseases. Because when you see some of the problems we are going through, it's because we are not able to detect some of the emergencies in time. And I know you understand what I'm talking about. We should put in place systems that will be able to detect any strange disease in your area and be able to alert and say, people here are dying of a strange disease. And that information is enough. The non-medical can say a strange disease is killing our people. For us, that's enough. That will trigger a system to go and investigate and find out what is happening. So please take it very seriously. We don't want a situation where we lose about 20 people in a district and nobody has noted it and nobody has raised any alarm. Madam Natalie, you can answer from there. You had only one question about expanding to Yumbe. I hope you know where Yumbe is.
Yes, thank you very much. A very, very important question. But I take it as, it's an aspiration that we should expand. And so I'm happy that the PATH leadership in the country is here. Madam Betty Mirambe is our country director for PATH in Uganda, and she's listening, so definitely we'll take it up. From a regional perspective, that's our desire, to do more and more work in Uganda. So definitely that's something that we are keen to do, to find opportunities for collaboration, working with the Ministries of Health and also other partners, within the country. So thank you very much for that, and we will take it up. Thank you.
Thank you very much. Now, ladies and gentlemen, allow me to invite the Honorable Minister of Health, Honorable Dr. Jane Ruth Acheng Ochero, who is the Minister of Health and also Woman MP for Lira City. She'll make her remarks and then officially open this meeting, and after that, launch 5 important strategies, documents, and 1 innovation. Join me, ladies and gentlemen, to welcome the Honorable Minister of Health, Dr. Jane Ruth Acheng.
Thank you very much, DG. This conference was opened long ago in the morning, so I don't know whether I'm still going to open it or just to say it should continue. But before I start, I was just wondering whether my sister here doesn't get tired. Does she get tired or not? Are you okay? Because many speakers have changed, but she has remained here. So, Mildred, are we okay? Okay, good. She's good. Thank you. Our development partners, I saw them here in the morning, UNICEF, USAID, WHO, and others. Our keynote speaker, my sister Natalie, our implementing partners, our elder, who is also passionate about health promotion and disease prevention, Professor Maswa, the DHOs and hospital directors, the resident district commissioners, LC5 chairpersons and mayors, chief administrative officers, district health educators, and the students present. Good afternoon to you all. Allow me first of all to apologize. I know I was expected here in the morning, but sometimes the activities that are lined up for the day are a little too many, and I just keep on running from one to another. But my heart was here, and I wanted to stay here the whole day. And I promised the organizers that when I step here, I will stay. And you can see I am still here. I want to appeal for your understanding. Number two, allow me to welcome you and congratulate the organizers on this second National Health Promotion and Disease Prevention Conference. As you heard, the first was in 2019, and this is 2022. Although the organizers have never told us the frequency of organizing the conferences, I want to assume that it will take place every 2 years or 3 years? Every 2 years. And this time it comes at a very appropriate time. As many of you are aware, we are handling a number of disease outbreaks. We have COVID-19. Sometimes people think COVID ended. But I bring you bad news. COVID is still with us. And the best news is that the positivity rate has started going higher. So you can turn to your neighbor and ask, are you up to date with your vaccination? And up to date means you received the 2, then you received a booster and another booster every 6 months. So if you are up to date, it means within a period of 6 months you're vaccinated. You can ask your neighbor, I'll give you time. And when you have asked a question, I need a feedback. So if you are up to date with your vaccination, put up your hand. Oh, that is good. So all of you last got your vaccine within the last 6 months. Those whose hands are up. Put up again. There is no lying. Very good. Let's clap for them. So for the rest of us who are not up to date, vaccines are available in every health facility that offers vaccination. Do not wait for the positivity rate to go above 5, to go to 10, and when you're at risk, you run to get vaccinated. Get vaccinated now. The other outbreaks we are handling are, of course, Ebola. And many of you will be aware about the famous monkeypox. Some of you locked the doors to monkeypox, but the Ministry of Health did not. We are protecting you every day. That is information that you can keep. We are on alert. We are carrying out surveillance, and we are protecting you. And if there is anything wrong, we shall let you know. And in this regard, allow me to warmly welcome and appreciate my chairpersons of the task force and also the district leaders from Kasanda, Masaka, Mubende, if you're here, Jinja, and all the others. If I have not mentioned, you know I am extremely happy to see you. Thank you very much for coming. I will now go to my speech. I'm not very good at reading speeches, so you will allow me to talk off cuff about health promotion and disease prevention. And I will start from a statement that the convener made most of our diseases in this country are preventable. And if, as a country, we had focused on disease prevention from the outset, we would have made a lot of progress. However, the challenge is health promotion and disease prevention is not cheap. It is not cheap. And you don't see the results real quick. Usually, politicians and planners want to see things that give a return in real time. They want to invest money and see an output. So you invest money in health facilities, you see people going out and some dying. That is an output. Yes, it is an output. When people die, it is an output. When people get better, it is an output. When you put equipment in the health facilities and people go check their hearts, check blood, do whatever, that is an output. But if you invest in educating the communities, if you invest in empowering the communities, if you invest in understanding the communities, you will not see the output in real time. It will take many years before you see the output. But when you begin to see the output, it is endless and it is enormous and it causes change. And that is why it is extremely important, if you're looking far, to invest in health promotion and disease prevention. And your tomorrow will be better than your yesterday. And that is where we must go. That is where we must go. With permission, allow me to talk about 3 things, and I want to focus on Kasanda as an example, with your permission. When we are talking about health promotion and disease prevention, let us look at diseases in a holistic manner, because every disease starts from the community. Even injuries start from the communities. Do you agree with me? Yes, because those people who go and cause injuries on the roads actually live in the communities. And if we had empowered them in the communities, they would know the dangers of bad driving, the dangers of not wearing their helmets, the dangers of not wearing seat belts. They would know. Because the best place to give health education messages is in the communities, where the problems begin and end. Every disease begins in the communities, ends in the communities. If that is the case, then why do we have ministries of health? Because then we would actually just empower the communities. Because there is the important aspect of funding. Funding must be available, and adequate funding, and real-time funding. By real-time, I don't mean the kind of funding where we need to start asking for supplementaries. That money must be readily available, so that if I declare an Ebola outbreak in a community in Kasanda today, the people of Kasanda can receive money in real time, not after 3 weeks or 4 weeks. The other most important aspect, and the keynote speaker stressed it, coordination, coordination, and coordination. We must coordinate. The partners and the communities themselves must coordinate. We cannot run away from the aspect of coordination. Allow me to thank the communities in Kasanda and Mubende. When Ebola was declared, we were almost 2 or 3 weeks late, in learning about the outbreak, because the outbreak started around 6th to 7th of September, and we got to know and declare on the 20th. That's nearly about 3 weeks late. Nearly. You can put it at 2 weeks late. And the person who volunteered the information was actually a patient who was admitted in Mubende Hospital, and he said, in my communities, remember he's very sick, almost dying, and people are attending to him. And he says, in my community, I hope you have taken note of that, in my community, people have been dying, and there are others who are sick. They are presenting with similar signs and symptoms like myself. And I don't know why you people are not aware. I decided to come to hospital because I want to know what is wrong with me. And when he said that, it opened the eyes of the health workers. So even as he was getting treatment and a sample was being taken to be run for many viral hemorrhagic fevers, because your country has capacity to analyze several diseases all at a go and know what the problem is. And you must appreciate government for that. So a sample was taken, and the health workers went to this community. And that is when they began to understand that there was a problem. And so work began. But I want to ask the people here, where were the village health teams? Why did they not report that people were dying in this community? Where were the LC1s, the parish chiefs? The PS mentioned here that we have the structures. I want to answer why. But it is no excuse. The reason why is because there is a limit to voluntarism. There is a limit to voluntarism. People will volunteer to do something for a while, and our village health teams have volunteered since 2001, when the village health team concept started. I know many of you here will be saying, but they are paid. Yes, they are paid here and there when they are carrying out activities. But it is time to think about sustainable income for them, just like any other person. So that they wake up knowing I have a job to do, and my job is to ensure that my community is healthy. I must check on them door to door. I must educate them door to door. I must have records of my communities, and I must report. But what is happening is that they also wake up and go to look for survival. So when they get back in the evenings, they hear that at Jenna Cheng's home, things have been happening. And tomorrow, they don't get another chance to find out. So we must think about our community health workers and ensure that they are motivated, they are facilitated, and they are valued and appreciated. That is when things will move forward. Many of you are now seeing good news coming from Mubende and good news coming from Kasanda. How is it possible? It is because the communities understood what Ebola is. It took a bit of time for them to appreciate that there is Ebola in the communities. It took a bit of time for them to understand that Ebola is not witchcraft. It took a bit of time for them to accept that when you have those signs and symptoms, you don't run to a witch doctor, you run to a health facility. It took a bit of time for them to believe that it is not my neighbor bewitching me, but I actually got in contact with Ebola. And the most beautiful thing that they have been doing themselves is moving door to door with determination to end Ebola. And the results are just amazing. You can see for the last so many days, we are not getting cases of Ebola. And many of the international communities are wondering, where is Ebola going in Uganda? Uganda must be hiding cases. That is what I always hear. Uganda is hiding cases, Uganda is not saying the truth, but we don't have anything to hide. We've never hidden anything. If there is any country that is so transparent, it is Uganda. Extremely transparent. Some of you will say, maybe the cases are in the communities, they are dying there. Absolutely not. Because every death in the community is being buried by the safe burial teams, and samples are taken. So we know if it is Ebola or not Ebola, and they can testify to that. That is the capacity you have built. Now, back to the communities. Are we able to build such a capacity? Are we able to build such a capacity to address the diseases that start from the communities, so that we can end extremely embarrassing diseases like cholera, so that we can end diseases that come out of not washing hands? Can you imagine being taught to wash your hands? This is what happened during COVID. There was even training to wash hands. Partners even wanted to invest in training you Africans to wash hands. Embarrassing. Should we really start talking about training people to use pit latrines? About training people to get rid of rubbish around their homes, as if we don't know where to dispose of this? If our great-great-grandparents had the sense of keeping our environments clean, what about us? Our biggest setback has been politicizing health education and disease prevention. Politicizing it, it is not politics. And too much democracy. Because if you come to Jen Acheng's constituency and you start saying they must build pit latrines, and of course the modified modern pit latrines, and her constituents don't have money, then you have made a big mistake. No, you have done the right thing. Because any investment put in today, the results will be seen tomorrow. So we must invest in health education and disease prevention. Empower the communities, give them opportunity to handle the issues themselves. Don't empower them and you still want to take charge. They know what to do. That is the challenge with most of us and with some of our implementing partners. Empower them, leave them to do it. They can do it. Always get feedback from them. Listen and get feedback. One of the things that we have been doing in Mubende and Kasanda, and many times people say, those people are always going there. Sometimes when we go, we sit back and we give opportunity to the communities to talk. Tell us what you know, your challenges, your fears. Tell us. And we learned very interesting things. Very interesting things. And I will talk about two. One of them from Kalwana sub-county, Chikandwa Parish. A man asked a question. If Ebola is transmitted by contact, and yet we want to cut our hair. I need my hair cut, and I have to go to a salon. The one who is cutting my hair will touch me, and is also using a machine that is using on several people. Will I not get Ebola? Beautiful question for you, the health workers. And another one asked, I don't know whether it was asked after or before we started getting a few infections in schools. They were very wise. They told us that there are some people who have had contact, but they are still sending their children to school. Why? Because their children have had contact with them, and they are going to school to have contact with other children. When the communities ask you such questions, do you think they don't know? They are very wise. That is why I'm saying empower them, give them opportunity to handle issues themselves, get feedback from them, use the information they have given you to teach them again. Because we also learn from the communities. So stay among them, learn their cultures, their values, and use that information to teach them. And the results will be amazing. Lastly, the importance of research among the communities cannot be overemphasized. But let them also participate in the research. And of course, data collection. Let us work towards digitizing data and getting data in real time from the communities. So as I conclude, I want again to emphasize about a few points: community, community, and community, funding in real time, coordination, research, digitizing the communities. That will make our work easier. And then, of course, take into consideration what I said earlier. There is a limit to voluntarism, and the people doing the work need to be appreciated. All the contact tracing that is being done in the communities is being done by our village health teams. Contact tracing. They have been empowered to carry out surveillance, do contact tracing, door to door, sensitize one another, and many of you will recall that at the height of the COVID pandemic, the village health teams carried out home-based care. You'll not say, but I did not go to their homes. No, you stayed in your homes, but they checked on you. And they were providing information and ensuring that you are okay. If you were not okay, then they would report immediately. So that is how important the village health teams are. Allow me now to appreciate our partners. We have been piloting the community health extension workers, I think in 2 districts now, Mayuge and Lira. And they have been flagged off after a 6-month training, 4 of which was academic and 2 of which was practical, to now go to the communities and start their work. We want to change the approach to work. The approach to work is for them to empower households, and that household empowers the next household, so that we create an army of households moving door to door, empowering the next, so that we can see the impact. And that will be presented to you maybe in the next conference. So allow me to appreciate all the partners that joined hands to ensure that we pilot this. I also want to appreciate those who have contributed so that we can have this second National Health Promotion and Disease Prevention Conference. Thank you very much. By the way, for me, it is one of the most important conferences. One of the most important. Anything to do with the communities is extremely important. I'm not saying things to do with the hospitals are not important, but let us prevent. Let us prevent people from getting heart diseases, from getting cancers, from getting malaria, whatever takes us to hospital. Refer to what the general manager said. Those who promote going to hospitals, unfortunately, it is majorly the politicians, unfortunately. I need a hospital in my constituency, I need a health center I need this, I need this. I am part of them. The reason why is because it brings us votes. Is it the right thing to do? No. The right thing to do is to prevent the disease. Lastly, allow me to appreciate through the Director General, the Department of Health Promotion and Disease Prevention, for the work that you have been doing in collaboration with partners. Surely you have taken us a notch higher. Continue doing the work and reaching out to the communities. Our MC in the morning said, health is wealth. When you're healthy, you can do anything. When you're sick, you will not be able to do anything. I will not leave this podium without allaying anxiety. I saw some headlines, not headlines, but I saw some write-up in the Monitor newspaper saying Ministry of Health plays double standards. Here we are saying there is Ebola and it is transmitted through contact. And then we allow organizations like MTN to organize Run for Babies. So we are playing double standards. And I want to state here very categorically clear that Ministry of Health does not play double standards. Every activity that we undertake is informed by science. How I wish that those who write those newspaper articles also understand science. And then you write. Because we have talked about research here. Understand science. People who are sick of Ebola cannot run. If you have seen the posters, you will see that they have fever, they have myalgia, they have joint pains, they are sick in bed, they can't run. And it is only when you have signs and symptoms that you can transmit to the next person. And by the time you have it, what are you going to do in running for babies? Will you be able to go there? All those who went there went to run. Did anybody go there to sleep with a blanket? Yes. Nobody went there to sleep. And they were running for a good cause. So Ebola is actually very easy to manage if people listen and if people write the correct statements. It is only transmitted by sick people. If you are a contact, but you are not yet having signs and symptoms, we keep you away. Because the fever comes all of a sudden. We don't know when it will come. That is why in Kampala, we are quarantining people. And in many other places, they are also under quarantine. So there is no double standards in this. It is science. With all those words, I now declare that this conference continues. Since it started long ago, it continues tomorrow, and then we shall close. But I cannot leave without answering a question that I was asked. I think somebody asked whether DHOs can also be other categories of people other than medical doctors. Was that the question? Yes. Medical doctors who have studied public health. I don't know whether you were trying to ask that can they be social scientists, maybe environmental health specialists, and so on. All the other categories can be good managers. But DHOs are not only managers. That is why we insist they must have studied public health. They must have studied public health. By the way, I know many people only know me as a pediatrician, but I also studied public health. And I last treated children nearly 10 years ago. But of course, I also love my roots as a pediatrician. Public health opens your eyes to see beyond management, to see deeper into disease prevention, to see deeper into the communities, to marry the two together. So you're not going to bring somebody who has done social sciences. He will know how to interact with the communities, but what about the health aspect? What about the disease aspect? What if you meet a community where people are getting stroke every other day? How will your head start working to understand that there is a problem here? Maybe there is a lot of salt intake in this area. So my son, you must have studied public health. I hope that answers your question. God bless you.
I want to believe, Claire, you are still okay. Join me again to thank the Honorable Minister. Another clap for the woman MP Lira City, who has assured us she will not ask for more hospitals for Lira City. But now let's go to her other final assignment. Honorable Minister, I was advised that you will launch 4 strategies and 1 innovation. The 4 strategies are the comprehensive health communication strategy, and I think Richard will show us how we do it. Then the National Community Health Education Handbook. Then advocacy strategy for promoting family planning services. Number 4, the communication plan for promoting antenatal care services. There is 1 innovation which we request you to launch, Honorable Minister. It is called the Uganda Campus for Health Education and Promotion. I also have some chief administrative, or Tuke Chief Administrative Officer, Simon Pute Akileng, Kao. Tuke, please stand up for recognition. Thank you very much for coming. I think that is it. There are RDCs, and they are requested for their names. They have not come. If there's an RDC who has not been introduced, the fine to, I think that should be to, the fine should go to who? Because Kabanda is really busy, I will not make sure him pay the fine. There is the Deputy Cow of Wakiso, Mr. Vyamkama Alfred. You are welcome, sir. Alfred. And then we have the Deputy LC5 Chair of Wakiso, Madam Barbara. You are welcome. So any RDC who has not been introduced, you have a big bottle of wine on Kavanda. Kavanda, you'll pay that wine for the RDCs who have not been introduced. So can we, now to join the minister to launch those important documents are the following representatives, just to represent the different stakeholders. The keynote speaker, Professor Maswa, the chief of party SBCA, the representatives or those representing UNICEF, WHO, USAID, and Uganda Health System Strengthening Activity. The directors of Ministry of Health, and of course, the convener who is Richard Kavanda. From local governments, we shall have one RDC, one LC5 chairperson of Masaka, a cow of Bukomansimbi, and one DHO. The DHOs normally have their representative, so that representative of DHOs can come. If I've not been given a very important stakeholder, please let me know. Yeah, you're tired. Meanwhile, a big clap for Claire again. Thank you very much, Claire. Professor Maswa is signing. Can somebody give for me to keynote speaker, please? The RDC. Director Public Health, followed by LOC5 Chair. Then meanwhile, the rest can sign. The symbolic one will be this one, then the rest can sign the other documents. When the director is there, I'm there. The Director General is still an MC. Since Thaisa has left me here. CAO, LC5, RDC, partners, UNICEF, WHO, USAID, Uganda Health System Strengthening Activity. DHO, thank you.
DG, I was waiting for official handover, but now, since you've officially done so, I will also expect that you will be doing the official signing so that there is no representation, but you entirely get to participate in that. That is launching the launching of key national health promotion strategies and plans. Like the minister did say, it is not a one-off thing because it is continuous. You may not realize the effects immediately. They will come at a later stage, but they will indeed be noticed. But she also did speak to the point that this requires quite a lot. There is a lot in terms of resources that has to be put in there. I particularly fell in love with the idea of the minister talking about a time to think about sustainable income for these village health teams, because there is only, like she says, there is only a limit to voluntarism. We can always talk about the goodwill, but at some point in time, there will be a discussion about, will I eat voluntarism at the end of the day? And in this day and age, the discussion or answer is always, the economy is biting hard. And she gave a very clear example that as a VHT, they have a family, they have key aspects to pay attention to. So probably by the time they are back, something has moved from bad to worse. So that sustainability program or approach is very, very key. As the signings do continue, that's to the comprehensive health communication strategy, the community health education handbook that everyone can be able to receive it. And I love that this is going to be an e-book like Dr. Kabanda earlier on did mention, that as and when you need to access, you can't just be able to, by tap of a button, using your phone, PC or whatever, be able to access this. But also the advocacy strategy for family planning, this is very key. Remembering that we had a mark of the 8 billion something number for the world. And what does that mean? 8 billionth baby or child was born in this particular month. But what does that mean? The positivity that comes to it, but also the negativity of if that population is just dependent, how does it affect economics and service delivery? Also the plan for promotion of antenatal care is as well key in part of the signings that we are having now. All right, I think this is officially done. A round of applause. And as the minister promised to stay with us to the end, she is actually still here with us. Key pointers that did come through from the discussions, all the way from the keynote address to the minister herself. It was very, very critical to speak to issues of addressing primary health care, especially from the keynote address, who spoke to that aspect, being able to improve equity. Equity is very, very key, that everyone is able to access in an equitable manner particular resources, but also aspects of access and then health performance at the end of the day, but also did put on the fact that it's not just what the services are provided, but how. It is not about having the hospitals, it is not having the doctors there to provide a particular service, but how are they providing that particular service? And then the end result, which also comes with behavioral change at the end of the day. Will we have more people thinking about coming back? If it is about antenatal care, it is, and it comes to the teenage mothers, do we have the safe spaces? How are they treated? And will that affect the behavioral change for them to say, I will go back for antenatal, or because I was mistreated, I will actually not go back at the end of the day. So I loved that it's not just about the services, it is about the how, which has an implicit and explicit value to how changes will be able to come through. Without wasting any more time, because the day is still long, but also that it is midweek and there is a lot of work to do. We're going to have a brief presentation from Dr. Richard Tweheo. And this presentation, which is going to precede a panel discussion, is going to focus on understanding the community health extension workers pilot in Uganda and insights from a baseline survey. More to what the minister was speaking about. Yes, we have these community health extension workers, but is there a sustainability approach? That was very, very key. A sustainability approach to them, and that they wake up knowing that they will have something at the end of the day so they can do their work with a lot of diligence and a lot of determination. Ladies and gentlemen, a round of applause for Dr. Richard Tweheo as we welcome him.
protocol observed, ladies and gentlemen. I recognized earlier that the slides are not very good, so it will be a little injustice to this presentation, but I'll try to focus where there are, where there are pictures, although there are lots of figures here. So this piece of work is titled Understanding the Community Health Extension Worker Pilot in Uganda, Insights from the Baseline Survey. I'm the principal investigator, so the baseline is a research evaluation prior to the actual implementation of this CHU pilot. Minister PS and the government, the Minister of Health, people have talked a lot about the CHU, and I'm going to speak about it. I do this, I'm Raymond Tweheyo. I work at School of Public Health Makerere, but I'm doing this on behalf of the Minister of Health and USAID, Uganda Health System Strengthening Activity, as part of the team and leading the research. Raymond is my name, MC, not Richard. Thank you. I'll skip that, it's an outline. So the background to all this, and the keynote speaker earlier talked about the primary healthcare philosophy or conference. This was a landmark start to formalize community health workers in a lot of the low-income countries. Right, and from then, many countries in low, middle-income countries began their policies around 2001, Uganda, the VHT strategy, Ethiopia 2002-3. Later on, Bamako initiative, saying that medicines in primary health care are restricted in the facility and need to go more to the community, the late 1980s. And then in the late 1990s, we gave these volunteer village health team members more responsibilities around things like HIV, WASH, etc., education and promotion. So all of you have seen this Immunize Now from a very long time ago, 20 years or so, and it is still a key message in health education promotion around the community health workers supporting immunization and many other community health interventions. So in 2018, the ministry brought forth a community health worker extension worker strategy, and I'll explain it a little more. For the research, which focuses on documenting and evaluating the pilot, which is being done in Iganga and Mayuge. The objectives are, the general objective is to explore acceptability and document the implementation process, evaluating whether the CHU strategy is effective in 2 districts of the country, specifically to assess acceptability of introducing this, to document how it is set up, to estimate the program costs and how long it takes for a strategy to be institutionalized, to determine whether the CHU strategy is effective for improving VHT supervision and VHT reporting, and then to assess whether this has an effect or an impact on community level indicators, so the health of the community. Now, this slide is generally to explain more of the science of the study for which this baseline is in place. And in brief, this is not very good, but the 2 circles at the top show that we have a population in 2 districts of community health extension workers and VHTs. So in 1 district, or in 2 districts on the left, this left big circle, we have CHUs who are being trained. And the numbers were approximately 178 for Lira, 168 for Mayuge. In Mayuge, the dropout rate was 1 person. In Lira, it was 12. So the follow-up of these CHUs from the training 6 months ago is nearly the same. So these are in the strategies of 2018, which is being implemented as a pilot, are based at the parish level, and they are going to supervise VHTs at the community level. And in here, we had planned to have 2 controls, Kabarole, Chotera, but resources only managed us to stop in Chotera, also with availability of other indicators. So for the baseline, those are the three objectives. One, to assess the preparedness and acceptability of introducing the strategy in a district. And here, a mixed methods approach with VHT survey, a household survey, a CHU survey, and key informant interviews of stakeholders. Then that middle box talks about assessing the situation of the VHT supervision and reporting. Again, that is mixed method. And then assessing the existing level of community health indicators. This just quickly shows the three districts, Lira Mayuge as intervention and Chotera as control. It's not a full experiment, so there is clear, it's okay to say these are the places where implementation is happening. And that happened, they were selected after a lot of readiness screening in terms of hosting the program. The key findings, on the left is Chotera, in the middle is Lira, and on the right is Mayuge, but I am mindful that you can't read this well. So in the control, many stakeholders were not aware about the strategy. They are mostly not knowledgeable. In both intervention districts, there is very high acceptability from the baseline findings, gauged from all stakeholders, so trainees, the CHUs, the VHTs, the district health team, the IPs, and other players, rated the training as very successful, very intensive, quite impactful. There was high political engagement for getting these CHUs on board through training and program setup. Now, the preparedness, however, is a bit lacking. It is inadequate from the evaluation. So in one of the districts, CHUs are generally understood as a substitute for VHTs, so that they will work as a substitute, and they're an additional pair of hands in a facility. And elsewhere, in the other, it was more understood like a supervisory layer, so different levels of preparedness. In terms of pooling them, registers, equipment, etc., that was also low. So from the VHT's perspective, they could correctly understand their role and their relational mandates, but they did not feel confident enough. This baseline was done end of September, rather beginning of September, when they had not yet gone to the community. Again, so regarding supervision and reporting, so supervision was generally above 85% in the control and in one intervention district. Were you supervised in the last quarter, at least once? Yes. So in one district, 65. About 50% of these visits are generally conducted by the district health office and with IPs. Now, the facility staff do less than 5% of the supervision to VHTs. That's a finding. However, so while from the VHT perspective, they felt the supervisions were adequate, and that they did good reporting, their supervisors say the reports are inaccurate and inconsistent. This is about community level indicators. I will go through it quickly and jump to the rest of the slides. So this is a survey, and the household populations, I know you can't read that, were 400 in one district, 283, nearly 300 in another, and 300 in the third district. So VHTs were nearly 300 across, apart from Chotera, where 2/3 made 200, and there were more KIs and nearly all the CHUs in intervention districts. So from here, in the household survey, we found that households that had had a sick child in the past 2 weeks were about 80% across, slightly higher in Mayuge. And under fives who had had a complete immunization, and these are women of reproductive age who had had a childbirth in the last 1 year, they reported about 80%. You can see that's nearly uniform across. Attendance of at least one ANC visit, starting the ANC visits in the last pregnancy within the first trimester was about 40% in Chotera, Mayuge, 67 in Lira. Skilled birth attendance was reported high, about 90% across. So this is from the household side. Now, I've mentioned this already. I'll skip that slide. Just to give a few insights about, let me not skip it, to give a few insights about what the participants said. It is really intense, reporting about the training. By 8 a.m., students are in class. 1 p.m., they break for lunch, and they continue between 2 and 4. I don't know whether they have got everything we taught them. Another says, for me, what I think most tutors should be from the community part. Let 70% of the trainers come from the community. Now, mind you, they had not necessarily done the practical, these CHOOS. Biggest role of the CHOOS is to give preventive measures on how to prevent diseases, to reduce expenditure of money on health issues, etc. Not so different, that is the role, being misunderstood. Their role is not so different. However, we expect CHOOS to do much better than the VHTs because they are informed and went through a training. We expect them to take roles at the health facility to help in documenting and other key things. So these were some of the key themes picked out from participants, and these are managers of the program, which is something that needs a bit of harmonization. Regarding existing community level indicators, and in the baseline, we mainly prioritized as a team, MOH and the supporting partner, maternal child health indicators in the baseline for household surveys. You know, surveys can tire participants. So this is a slide that shows at the bottom, if you look at the bottom bars, did you have a sick child under 5 within the past 2 weeks? Above 80% or 97%, nearly universal in Mayuge. I don't know if you can see the key there. So the darkest color is Mayuge. Whether they were treated, that's the topmost bar, within 24 hours by a VHT. You can see that one of the least treatments is in Mayuge. So this is an intervention district, and the community health program, we have less treatment for nearly universal sick children. While the 80%, you can see Chotera treats nearly 85% of their children. So what caused most of this sickness? It was mainly fever followed by cough and least diarrhea. And that's consistent with DISH2 data that I'll display shortly. So this is a comparison between DISH2 and the survey, household survey. Unfortunately, the DISH2 is showing absolute numbers and not necessarily proportions. But you can see that at the bottom of the left graph, number of sick children seen, the district with the longest bar is Chotera, and that goes across for treatment, etc. And the key message in this slide is the main reason for those treated for fever within 24 hours was bigger than the other graphs. I hope you can see this. Yes, so this is the family planning users, and this indicator shows number because there is no denominator, all users. Again, Chotera has the highest number of FP users, information and methods across time points, and the other, and this is data aggregated across the quarter of last year into the first quarter of this year, because this is a role for our comparative studies. This shows proportion of under 5s who are treated within 24 hours for fever. This is proportion to be able to compare between the districts. So where the graph doesn't proceed, there is no data, but you can see that between Lira district and Lira city, the gray and the red or orange, they're about comparable. But Mayuge, the proportion of sick children seen keeps dipping. It's on the lower side. The purpose for this slide is generally not comparison per se, but to see the current status. So this compares on the left children under 5 seen and treated within 24 by a VHT, while on the right, it is those who are referred. So we can see that on the right side, apart from that data point that's above 100%, that should be an error, it's generally under 20% of sick children seen. So this shows screening for MUAC, a nutritional indicator, but general screening for under 5 children. And this is still dish data across the last year and one additional quarter. I think the key message here is that under 10% of all children are screened for nutrition, generally. And this is, so the one tending to screen more in that graph would be literacy, the red graph picking up, but that is not consistent. This is a key indicator to which needs to be eliminated. So proportion of pregnant women that deliver at home, this is under 1%, and it's fairly consistent with the survey where women self-report that they had a skilled delivery, 90% across. So when you compare this with delivery in facilities, I don't know, it's not giving me the next slide. Yeah, this is deliveries in facilities. So by proportion from dish to each quarter, you expect that cumulatively 25% of women should be in the facility. So that dotted line shows the target, the 25%, and anyone near 25% is doing very well. And across Lira City and Chotera, the performance is between 20 and 25, meaning every 4 in 5 women deliver in a facility. But Dish 2 shows that 1 in 5, or under 10% in Mayuge and Lira district, the delivery in facilities is low. Okay. This is comparing deliveries in facilities that we've just seen with delivery at home, which is consistent. So near 25% means all are delivering in facility, or nearly all, while this shows below 1% are doing it at home. It could be that we have a bit of underreporting, but at least the percentages are low. Immunization up to date, this is a VHT indicator. Again, on average from their reports, you can see that Mayuge, Lira City, and Lira District are between the 10 and 15% mark, but Chotera is much higher for up-to-date immunization. It could be if, so the caveat here is we don't have the reporting rate from the VHTs, it's from another data source, and this, we've had it recently. So, sorry. Fully immunized by 1 year, this is Dish 2 data. That's about 20 to 25%. This is facility data. Not quite consistent with the survey, so it could mean that there is a bit of under capturing of data in facilities because some immunization is done in the community. So the key conclusions and discussions from this pilot. One, for all future CHU trainings, we said the curriculum needs revision to repackage, to put things that are more practical for trainers, because these CHUs are to be in the communities. Their deployment kit needs to be standardized right from the word go, to be planned. So part of this is already being done by the implementation districts as feedback they've received throughout their training. Ongoing CHU implementation needs to clarify roles of the CHUs to stakeholders, so there needs to be a stakeholder engagement. There needs to be a clear entry program into the community and how they will have relational mandates, because some thought supervisors, right from their strategy, they say they'll be supervised by a health assistant, a facility in charge, and a parish chief. But from management, we know one supervisor to one staff. So that needs to be sort of harmonized and collaboration worked on. So these districts, so since districts that have varied implementation partners and supervision models, we propose that the supervision model needs to be sort of given a little more thought. It's not well structured in the current implementation. And there is some evidence to this in the protocol of what works, group supervision, focusing on content versus frequency, and that kind of thing. And from the baseline, we could see that the single visit supervision was only 75%. So a communication strategy is vital to bring partners together to talk about these relational roles between the supervisor, the CHU, and their supervisee, the VHT, to strengthen the community health program. We talked about peer mentorship, so CHUs have a higher level of training compared to the VHTs. So these skills need to be mentored, not only to the household, but to the VHT, so the two working collaboratively as co-implementers. 1/3 of all CHUs in one district and half in another were formerly VHTs, so there is need for replacement of VHTs so that there is no gap at implementation level. We've talked about supervision style, and also the issue of spot checks. So most of these existing supervisions from the baseline are spot checks, and this needs to be sort of moved to supportive supervision. Data management and reporting is critical, so we could see the main concern of the district managers is the quality of reports, the inaccuracy, which is also a concern in facilities themselves. So that is an area for CHUs to be strengthened. They need to be tooled. That is lesson number 2. And the last one there is ongoing on-job coaching for them as mentors for data recording, extracting, reporting between them and the VHTs. So in terms of okay, this doesn't like to go back. I'll skip that. But in terms of the community level indicators, it shows very clearly that the disease burden is still high. In 2 weeks, nearly all households, 80% to 97% in one district have a sick child. So these community programs need to be strengthened, and the preventive measures that we're talking about in this conference. There is ethics for this, and this demonstrates stakeholder meetings that we are privy to participate in and document the ongoing processes. And this study basically keeps researchers engaged and participating and disseminating continuously to the implementers. Thank you very much, and I'd like to welcome questions. Back to you.
Bigger round of applause to Dr. Tuweheyo, who's given us an aspect of the approach and what exactly is happening on ground and the effects that are coming through. And probably that is what would best the discussion of, do we need to have some changes in some way? How best do we approach the different categories in different areas? Because of course, different districts could require maybe a different approach to dealing with this. But to be able to take on a panel, and I'm going to ask Dr. Tuweheyo to actually stay, I'm going to have Dr. Daniel Kabayenze to come through and take on this one. And in that, basing on the presentation that Dr. Tuweheyo has made, the panel discussion is going to seek to deal with issues of institutionalizing and operationalizing of the community health workers in Uganda, more to what the minister was talking about. How do we embrace them and make them a part of a system and not just look at them as providing voluntary work? because it will come to an end. Like the minister said, voluntarism will definitely have an end to it. So how do we contextualize them in the broader perspective of the system? And ladies and gentlemen, let's welcome Dr. Daniel, who is taking over this aspect. And as the panel discussants get to answer that, I know if there are any questions that were meant to be directed to Dr. Tueheo, Dr. Daniel will be managing that particular session. So let's welcome him. He will let us know who the panelists are, and thereafter we'll definitely have an engagement with the questions coming through. Dr. Daniel, welcome.
You may wish to clap for Mildred. Thank you very much. You're very kind. Allow me to invite the next three presenters. We are running short of time, so you are going to be a little more agile. I'm going to ask Alfred Kato to see me, DHO Bukoma Nsimbi, Ronald Ochatri, and Dr. Professor Richard Idro, and Nestroy to come up here, and in 2 to 3 minutes, give us highlights in what they think based on this panel discussion, what their views would be. And I'll ask them to sit here and give us about 2 minutes each. I'm very sorry for allowing that, only very short. I know you prepared very excellent things, but to allow us to digest what needs to be happening. When you sit, you switch on your microphone. You can sit there. Right. Where are our other two people from Bukoma Nsimbi? Okay, so I only have two technical people. We wanted people from the community. Okay, so Professor, you'll come on after Dr. Ochatri has made some remarks. 3 minutes each, since that we have saved some time. Okay. Go ahead.
Thank you very much. Thank you very much, Director. All protocol observed. My name is Dr. Ronald Mireo Chatri. Allow me to start by thanking Dr. Raymond for the very elaborate study that he has undertaken. As Minister of Health, if you see or if you've already heard what the current or the previous speakers were talking about, we are on our way going to promoting health and preventing diseases. And one of these initiatives is bringing in another layer of community health workers. I'm sure we all know that from the Honorable Minister's speech, we had institutionalized village health teams to be another level of healthcare workers at the community level. And over the years, we did make an evaluation of their workings. And it was that evaluation which was done with support of USAID, that's Pathfinder, in the year 2014, that gave us a sense of direction and probably to rethink whether we could do it differently. Needless to emphasize the fact that the issues of taking health care to the household level cannot be overemphasized, and having more numbers probably is better than having less. We looked at what happened in other areas. We always like talking about Ethiopia, and if you remember our great Millennium Development Goals that we championed as a world, where Ethiopia is the only country in Africa, if I'm not mistaken, which was able to fulfill all its health-related goals. And I think we thought we needed to learn something from that. So all these are the reasons why we thought, yes, we have the community structures, we want to take health at the household level, we are having a number of initiatives and interventions, but we are not reaching there. So as we are going to go to the Sustainable Development Goal and universal health coverage, we thought we needed to do something slightly different. And that is really what informed the idea of having the community health extension workers. So we have started the pilot. It may be late, but it's not very late because 2018 is when we thought about the idea. So with the support from partners, we have been able to carry out these learnings, and we have done the trainings. We are really getting there. We thought we would have a lot of learnings from the 2 intervention districts and the 2 pilot, the 2 pilot districts and maybe the 2 control districts. And there are also learnings that we are going to have in Masaka and Bokoma and Simbi with another model which is not very different, but with support from Kofi Uganda, and also with support from Global Fund, that is UCREP. We also want to have some learnings in the eastern part of this country. So why we are doing all this is because initially our concept of this was that we wanted to do a full-scale training of this cadre of staff whom we would place at the parish level, whom we think fits perfectly well with our parish development approach of taking services to the parish level and eventually to the household. So having that at the back of our mind, we think this is a good journey that we've started. We've done a lot of learnings. We have USAID that is supporting us with the training and the learnings, and hopefully after 1 year from now, and hopefully also when we have the next conference, we should be able to come and report on the progress. But I'm very, very sure before that time when we have the next conference, we shall have already started rolling it out, because the indications now is that this is really the way to go. And I'm very sure that collectively, with support from the overwhelming support from the district leadership, both technical and civic, we think we should be able to put health at the community level and have that layer of cadre that will be able to help us take services to the household level. I'm sure there are issues to do with the costs that people may be thinking about. Yes, just like what the Honorable Minister and the Chief Guest said, the initial cost of investment in community health services is huge, but definitely there's good return on investment. And that is our consolation. So if we want to have good health outcomes, we must invest, and we must invest now. Many countries that have developed have actually invested, and invested heavily. I always see people lamenting and saying by the year 1962, when we were getting our independence, we were at the same level with countries like South Korea, many other countries they were mentioning. But these are countries which are now first world. What is the magic bullet? It means they invested, they sacrificed. So it is up to us to determine what we want for this country. If we want to have a healthy and productive life now or tomorrow, then now is the time to invest. And investing in community health is definitely the best way to go. And that is why the leadership of Ministry of Health think that that is the area we need to explore. We are doing learnings, and these learnings are going to help us to perfect whatever is supposed to be done. You have already seen the recommendations by the consultant. The recommendations are touching on a number of things that we had not envisaged, and we think ultimately we'll address these going forward in the subsequent implementations. We really should be able to address those and see the costs involved so as to make projections and then see how we can collectively improve the health of our people at the community level. There are definitely other areas where discussions are being done on whether we should recruit and have already existing cadre of staff at that level. Yes, that discussion is definitely good, but what is important is for you to do the community type of work, the orientation definitely has to be different. The orientation has to be different, that's the first thing, and also looking at the costs that we are spending to pay these people, it's much, much less probably than what a professional or a professionally trained cadre would be, at the current level, would be receiving. So those are some of the things that we weighed. We want to veer into that. We think is the right thing to do. Hopefully, by the time we have learnings after 1 year, we should be able to come and make an evaluation and see how best this can be done. Thank you very much.
Thank you, Dr. Ochatri. He's the coordinator for VHTs and the same program in the Ministry of Health. So now allow me to invite Professor Idro. Idro is an expert in child care and he's a lecturer in Makerere University. So we allow Dr. Richard Idro also to use the next 5 minutes since the other two people didn't show up. We are sharing the time.
Thank you very much, Chair of this session. Honorable Minister, and all protocol observed. Thank you, my OB, Dr. Chatre and Dr. Toheyo. And I would like to start from the angle at which, where he ended. Over the past few months, I've been trying to think about what are some of the other things we can do to try and improve some of the outcomes. And these community interventions, I thought, was one of the best things. And I was very grateful. I'm grateful to the commissioner for inviting me for this particular session. If we look at our indicators, we have brought down infant mortality, but it is stagnating now, especially related to issues around the neonate. Preterm birth, birth asphyxia, neonatal infections, but also the others, malaria is getting back, there are diarrheal diseases. And then we have the other aspect of events in the older population, the NCDs. We are almost having an epidemic of the non-communicable diseases. 1 in 4 adults has high blood pressure. Road traffic accidents, people are dying every day in large numbers. Alcohol and drug abuse, and alcoholic liver diseases, lots of this. And recently there was an audit of death in one of the rural districts in Germany. Amongst adults, almost 60% of the adults who died from things which were related to this. And I thought to myself, what other things could be done differently to try and address this? And other than the community health workers we're talking about, and my question was, why not use already trained personnel who exist in this country? Uganda is blessed with over 70,000 nurses in this country. They are available. Over 10,000 of them are unemployed at the moment. We produce between 4,000 and 5,000 new nurses every year. And this resource is available. Young people who are trained, although the training may be, in the majority of cases, may be targeted towards curative diseases, but we also have the comprehensive nursing training schools, which could take on this role. And so where did I think that this could be applied? We have the Paris Development Model. This is the government intervention program, which is driving all government programs at the moment. And so if we were to take and employ and create positions of community nurses in each of the parishes, starting small and growing those numbers, cost allowing, because this is going to be a really expensive venture, because we have over 10,000 parishes, about 10,590 odd parishes in this country, starting and phasing this slowly so that these responsibilities are taken up by nurses. What will these nurses do in these communities? One, they can register all birth and all pregnancies, all deaths, so the kind of things which the minister mentioned, where 20 people died in an area before being notified, will not occur, because the nurse responsible for that parish will have identified this much, much earlier. They will be able to review neonates. We are not lowering our neonatal mortalities, but they will be able to review all neonates who are born in these parishes, and cater, observe, and update all vaccinations, maternal and child health services ongoing in these different areas. We are having trouble with things like multi-drug resistant TB. These will be the individuals who can directly observe and administer such interventions in the community. School health, we have over 15 million children in school right now, and each parish has about a school. So having these nurses will be able to lead the school health. Here we will directly be allocating the presence of a nurse to be able to lead school health services. Coordination, the proposed national health insurance scheme coming in future. This will be some of the individuals who will be able to do. But one of the other challenges which we are having is delays in a referral, an appropriate referral. And having such trained individuals will be able to lead this. These are just some of them. But a bigger one is to screen and initiate treatments early. People above the age of 40. If I was to ask how many of us here know our blood pressure this year, you will be surprised, including us who are in the health sector. But these nurses will be able to perform these roles, and we have written down directions of guidelines for them, that every year somebody is able to take your blood pressure in the community. We may be able to phase it and start maybe in the urban areas and then proceed. But covering this with one nurse in a parish will, we have tried to work out what it will cost. The cost is not small. It will be about 180 billion a year. That is at full implementation. But if we were to double this, 2 nurses, because most likely we will need that. At the end, the benefits will be massive. And my feeling is, if we are to do something, let's do it right. Let's do it well. Let's do it smart. It may cost us a lot, but this may be the initiative of something which we can do. And by the way, when we pay them, they will pay taxes. Part of these taxes will come back to government. They will be able to cater for families and the extended family in Uganda. These were my thoughts, slightly different from from training individuals, but rather than taking people whom we already have, our nurses. Thank you very much.
Thank you, Professor Idro. I want to take this opportunity to now open up this for discussion. Our time is now well spent. Mildred, I don't know how much time you gave me, but we will allow people to maybe ask 2 questions for each participant. So we will expect maximum 6 questions from the audience. And I would want to see the hands all at once so that we do not have to keep moving. So we are going to have 6 questions, and I'm going to look out and put show hands, and maybe 3 ladies and 3 gentlemen. All right. We've got a lot of interest. More hands are up. So, because of the light here, I may not be able to see. So the gentleman on 3rd row, here, 1, then the one next 2, and the one 3. So I have finished that side, so I'll look out for 3 ladies this side. Number 1 is here in white. I don't see any other ladies on this side. Okay. Yeah, but I'm counting from this side. Okay. Too much democracy. Okay, the next lady that side, that makes it 5. 1 more hand. So, the gentleman right in front here, in gray. Thank you. So we've gotten all our 5 questions for now. If we have time, then we shall call out. But if you're asking your question and you make it brief, then we have to give other people chances to also ask. Thank you.
Yeah, thank you, moderator. DHO Marachastel, Dr. Paul Onzubo. I thank the presenters. My concern is about medicalization again of interventions by community level. The VHTs, you remember there is something called integrated community case management. So we have taken medicalization to the village instead of using these people for referral and the community mobilization. We need to think about that. We have really overloaded them despite not paying them adequately. I cannot disagree with what Dr. Idro or Professor Idro has raised. And I think we may have no choice but to spend there. Thank you.
Thank you very much, the presenters. My name is Hannington Tewaijuka. I'm a health educator. I come from the remote oil-rich district of Bulisa. I will not forget a situation where I was conducting a community dialogue, and I told the community in the presence of an in-charge, a clinician, that when you do the following interventions, you'll stop falling sick and you'll not even come to the health center. Literally meaning that 75% of those patients in the community will stop coming to the health facilities. In reaction, the in-charge said that I am not going to continue funding anything of community health because you want the cow actually to dismiss me when patients stop coming to the health center. I now want to ask from now, is it true? Is it a hangover of verticalism? Is it a real problem that health facility clinicians or doctors, health workers, have a thinking that when health promotion and disease prevention is rolled out and people stop coming to the facilities, Honorable Minister, will you invoke any law to dismiss or suspend or to take stern action against health workers in those facilities because they are not seeing patients? That could be one of the worries why we are not seeing the will to support this intervention too. And probably as I summarize, health promotion, disease prevention requires human resource. I am requesting the ministry to do aggressive intervention to ensure that health educators, health inspectors are increased in numbers at those community levels. Because right now, as we are doing PDM, for your information, thank you so much that you have a good, health educators are good communicators. By virtue of that, I was assigned to be a district PDM facilitator in Bulisa. And the PDM is offering a good opportunity for us to reach organized groups. May I ask therefore that you increase funding for health promotion, disease prevention, so that we go and meet these people in the communities who are already mobilized into groups, enterprise groups, so that we can integrate our activities. Lastly,
thank you very much. We had 6 questions. I know we shall get more time.
Thank you, Doc.
Thank you.
Yeah, thank you. Direct to Professor. Thank you for your submission and observation. I want to believe that is something that would drive us ahead. But I was concerned about 2 things. First, sustainability. While you are talking about these nurses being deployed up to parish levels, I was getting back to my district in Lira, where I've even failed to attract appropriate wage for paying the health workers. I want to believe a number of us in the districts have not recruited even our health workers up to 100%. Meaning while we have those health workers who have been trained from other institutions and they're there in private practice, within the public healthcare setting, we have failed to attract the requisite number that should be able to deliver services. So going forward, I would think that first we strengthen the existing health system that we have, and then number 2 is about the community health extension workers. There is evidence already that they are a key resource in health promotion and disease prevention. And I want to believe while we were piloting these, there were already people moved out to compare with what was happening outside the country. I understand at that time the team went to Ethiopia. And they actually realized that these same cadres of people we are trying to train as community health extension workers were also in Ethiopia, and they have greatly improved the health indicators. Talking about sustainability of healthcare services and health promotion, I want to believe this is a resource that if we invest in, one, will not be extremely expensive, unlike in recruiting the professional nurses, and that will actually help us to ensure sustainability.
So as you summarize.
Then the last thing I was looking at is issues of remuneration. The same cadres of health professionals working at different levels, but with different remunerations, because I was imagining while you are submitting that this parish staff, the health workers who are going to be recruited at parish levels, I don't know whether they would be paid the same amount of money like other health workers in health centers that we are now paying. Otherwise, the cost would be extremely high and would not be sustainable. Thank you.
Thank you very much. So whoever now has to just give comments, keep it to 1.5 minutes. Because
Okay.
some may not be questions from
Thank you
current
very
observation.
much. I'm Mabalo Emily Okumu from Gulu College of Health Science. I'm a clinical instructor. I'm going to talk in the aspect of us sending students to, I'm still a new clinical instructor for only 3 months at Gulu College of Health Science. In a sense that we normally train our students, the clinical officers, the pharmacies, and the rest of it. I'm in a view that the ratio of students to tutors, that ratio of student to tutors is really low. And most of the students being produced out there, they are really not okay in the aspect of, doing an integrated management of what? Of patients and, integrated management of the whole aspect. Now, here is my question. Why don't you empower, since the majority of students, if you go to the health centers, they employ very many students, and if they are well equipped with knowledge in class, they can be sent out there and help the community. And then secondly, why don't they help the students who are going to the facilities during training and give them enough time to help in a sense of, teaching them in the facility? Thank you.
Thank you very much. Okay, the
Yes.
last question from this side before we move. And I realize everybody is asking two questions, so in
Okay.
effect.
Thank you for your time. I want to bring to notice this house about some special communities, I think, which are normally forgotten. When we are in this discussion sometime, the perception is the general community. My name is Jack Sibointole. I work as a senior health educator for Uganda prisons. You well know that the systems that we create, for example, the CHUs that we are training, they may find difficulties in accessing and giving service in barracks communities, the police, prisons, and UPDF. Now, we have two special communities. We have a community of prisoners and also our soldiers. And the burden of disease has got some unique differences with the general community. Dr. Ochatra, I think, and Dr. Raymond, in the presentation of your pilot, I saw some of the indicators. The burden of disease on this other side seems to have some differences. So in piloting this important component of health system, I wish you to bring the survey on our side of prisoners and soldiers so that you have findings that can be well generalized also in our special communities. Now,
Thank you thank you very much.
Another important point.
If you can summarize the point, because this whole session has only 5 minutes to close.
Yes, just give me 1 minute. There is a silent epidemic of drug and substance abuse in schools. And the health system or the health structure in schools, we all know that is still weak. And most of our children spend more time at school than they do at home. So our CHUs will not find these students at home. Do you have plans to create this structure, at least for the education system, in order to improve things like drug and substance abuse, teenage pregnancy, and GB issues. Thank you.
I think we shall only allow one question this side before they can answer. I think we already had 5 questions from this side. Please, whoever has the microphone, cross to this side. We selected one lady first here, and then the gentleman in gray.
Thank you very much. My name is Subo Sara, Karanga District Local Government. Mine is very simple, goes to Dr. Chatre. The VHTs who've been in existence, will they be given chance to be selected as choose? Then those ones who've been supporting us in several activities as VHTs, is there any plan from Minister of Health to support them? Thank you.
Oh, thank you. And finally?
Yeah, thank you for the opportunity. I am Frederick Ouma, a senior health educator from Busia District. Mine is on this choose. I don't know how many have been allocated per parish, but my fear is too much workload for one person, just like we have been saying. Some villages which have many households, the workload has been compromising the work of the VHTs. Then on the issue that the professor presented, the submission on the nurses, community nurses, we had in Japan where they used to have public health nurses, and they did very well in reducing the infant and maternal mortality. However, if the resources could allow, employing the nurses at the parish level would be the best way to go. Thank you.
Okay, thank you very much for all those wonderful additions and comments. Now we'll open it up to the floor here. Majority of the questions came to Professor Idro and Ochatri, so we shall start answering going that way. Please, if you can use about 2 minutes each, and then we shall close this session and hand over to Mildred.
Thank you very much. I essentially had one question, and it's about cost. The resource envelope is small, it's very small, it's tiny, and this is a very expensive intervention. Do I have an idea where this money will come from? At the moment, I don't. But I think if in the ministry, people could sit down and start evaluating some of the advantages, we may find some resources elsewhere. But there are also other ways of looking at it. Reallocating some responsibilities and reallocating responsibilities to even existing staff to take up some of this. Talking about, I just mentioned schools as a special group, 15 million children in schools. But we are also having, our life expectancy is increasing in Uganda now. Just 15 or so years ago, 15, 20 years ago, men used to die at 41, women at 48. Now, we live to 63, 61, 62, 63 years. We are having a new disease pattern in that age group. We need to rethink many of our actions. Even the community, the health promotion should start preparing, taking into account this new emerging population of the elderly in our community. And I think these nurses will do well. Thank you.
Yeah, thank you very much. Thank you, members, for those questions. I think I received the biggest share, bigger or biggest share. Okay, it was to 2 of us. The issue of health at the household level, I think we're all in agreement. And then again, the issue of prevention sometimes is not just by talking, but sometimes even by intervening. And if you look at why we have placed some curative services in the hands of the community structures, is really a stopgap which is intended to take immediate action, which I think eventually we think is going to be removed if what we want to achieve at that level gets achieved. So right now our emphasis really is to try to see how we can empower the community health workers with the requisite knowledge to be able to help us in issues of referrals, first identifying the problem, and then quick referrals using our systems which are in place, so that we can be able to help our communities. The issue about whether health workers will lose their jobs, I think it's not for me, but I think it is only right. I remember, I will not mention when I worked in the district local government, there was one of our colleagues who would tell us that they regret having eliminated guinea worm. Now they have run out of jobs. That was a big joke, but I think he meant it. But I want to believe that there are still so many things that we can do, health workers can do. If you can borrow a leaf from the developed countries, the health workforce, they are still continuing to say that we need more health workforce because diseases are changing trends. They will definitely be there because there are many other things that we can use to promote health, even as professionals. The issue of special interest groups, incidentally, this study, the baseline is in those two districts, and I want to believe Lira, for example, Lira district and Lira city must be having a hold-up place, a barracks, maybe a prisons or a barracks. I also believe that in Mayuge there should be one. So we do know that these chiefs, for example, are 2 per parish. We've tried to be very specific. We said there must be a lady, there must be a gentleman, so as to balance, because they have different, they can address different concerns in the community. So that is how the planning is. So I want to believe that when we are going to continue doing the learnings, we'll take care of your concern, and we'll see how the issue of the special interest groups can be taken care of. And therefore, the other issue about how do we select them? Can we allow the VHTs? Yes. If you remember from the presentation, more than 50% of one of the 2 districts had VHTs who were enrolled as Qs. And then the other one was about 33%. So yes, we give priorities to first the practicing VHTs, and then where we don't get them qualifying according to our set criteria is when now we ask communities to go ahead and give us whoever they think can fit and be able to work. The training of community health extension workers vis-a-vis the training of course, of our nurses and midwives who could undertake, comprehensive nurses who could undertake this. I want to say the training, the structuring of this training was deliberately done. It took into account the level of education, it took into account where these people are going to work, it took into account how much are we going to pay them. So when this was done, it was done with the support from the Ministry of Education, the National Curriculum Development Center, who guided and supported very tremendously the partners, Ministry of Health, to be able to come up with this. We had the technical knowledge, but they were the ones who took lead in this. And also public service was able to guide us. So really the structuring is in such a way that it is tailored to address the concern by that cadre. Maybe when we think about the angle of my OB, actually not only my OB, but my classmate and deskmate in senior 1, would probably now look into the other issues of how do we retailer that, and then where are the resources coming from. So those are the things that we probably need to do. Lastly,
we still have a round of questions from this table, which I couldn't see because I was seated behind this podium.
Okay.
So,
the plans for schools? Yeah, the plans for schools, I know we have school health program, and then I know definitely the issue of drug abuse is not only in schools, by the way, it is even in communities. These children are in schools, yes, but they're also in communities. I know that actually more of the drug abuse cases that worry us are more in the communities, because the one in the schools, actually teachers try to see that they can actually handle it. So this is a challenge for all of us. I think we have gone through, the training has actually taken care of almost all the areas where we think these guys should be able to help us at the community level interventions. And this concern is right, and as we are going to do the learnings in the next 1 year, we'll be able to open our eyes to some of these things, and the issues of lifestyle diseases is top on the agenda because we know that's where the new shift is. Many of our diseases and actually most of the conditions are now lifestyle conditions, and just like I said, we have learnings also in the greater Central Region, Masaka and Bukoma and Simbi. You realize that we are also doing the issues of trying to take people's BP, assess blood sugar levels, and all those are lifestyle diseases, which we think can be done at that level at a minimum training background. Thank you.
Okay, I'm going to allow the table here, the Honorable Minister and the Director General to, do we have the microphone already here? Somebody to bring a microphone here. Somebody to bring the Minister, Honorable Minister, microphone. Yes. To hear you, you have 1 minute as the Minister comes up.
Okay. Me, I want to answer a question. I'm not going to ask a question. I'm not a panelist, but something has struck me. Let me tell you people, and I want to answer Dr. Richard Idro. The best people to do health education and promotion in a community are the communities themselves. Never take a nurse there. They will not accept, they will not listen. It is the communities themselves. They trust themselves, they listen to themselves. All they need is to be empowered. And the rest is history. And they are cheaper than the nurses you are looking at. Those ones have been trained, they're at public service level. They are not going to accept 100,000, 150. That one is not their pay. I think nurses are now at 4 million or something. And you take a 4 million earner to a community where there are no toilets and so on. It is the communities themselves. The concept of the community health extension workers looked at picking people from the communities. Ochatre was not explaining. Picking people from those communities and taking them back to the community. And what was emphasized is that you must be ready to go back to your community, to stay there, to live among the people. Even if you are a lady, if you get married and you transfer, we lose you. But if you get married and you stay in the community, you continue. Remember what I said, empower the communities. Give them opportunity to handle their health issues themselves. That is the primary health care you learned long ago. By the communities, for the communities, by themselves. Not any person. If you deploy Jenna Cheng to the communities, I will fail. Because they will not trust me. They will not. Cheap things that yield results. Cheap things that yield results. That's all I wanted to emphasize, DG. I don't have any question.
DG, you want to give a supplement?
No. I actually had no question, but I wanted to remind you there are some people online.
Oh, online. Okay. We must have missed them. Let me give to
But there is a question here.
Okay.
Thank you, Director. Mine actually isn't a question. When Dr. Idro wrote an article about community nurses, I was attempted to write back. I wanted to respond to his views. And it's good that when he heard about this conference, he was interested to come and share his ideas and pick more issues on community health. On top of what the minister has responded to, in Africa, people are so much attached to their culture, the language they speak, and all that. And community health interventions should be in sync with that. The idea of community health extension workers is embedded in the thinking that somebody should be able to understand the culture of that community, and somebody should be able to speak the language of that community. we have had a lot of technical discussions of having professionals. And there are a number of issues. Professionals would wish to go back to school. They would wish to transfer services from one place to another. There are so many things. They may not be able to walk from house to house. They may underlook people in that community, especially if they feel that they are more educated than them. So there are a number of things that you must think about for you to be able to say that, okay, will Richard be able to relate very well with the members of the community code or MASWA in that community, if you are able to have that under that. And then, Dr. Idro, we have nurses currently attached with the center tools. I think the very first question would be, have they been effective in promoting health and preventing diseases? What are the key issues at parish level? Because the center tools are at parish level already, and we have these people in there. So have they been effective? So the current strategy has been able to look through all these other different ideas and the current structure and the bottlenecks and all that, and be able to say, no, we can't go through this direction. We need to move into this direction. It was just a submission. Thank you.
Professor had something to add?
Yes, Professor Maswa.
No, very briefly, the issue of people in health facilities not being happy when you say stop people from going to health facilities. There are two tracks. There are people whom we want to encourage to go to health facilities more, antenatal clinics, skilled attendants at deliveries, checkups when they need to. There are also people whom we don't want to see going to the health facilities, like people with diarrheal disease coming again and again and again. So we need a balanced way of looking at that issue. Not to punish people who have encouraged more women to come for deliveries. Those should be rewarded. But punish those who have got recurrent people coming with diarrhea, and doing nothing about it.
That is a new spin to what we want to see in the health facility. There are things which actually must happen in the health facilities. Then finally, Dr. Tweheyo, the researcher, I also had questions for you, but probably because of lack of time, you had 5 specific objectives. But when you gave your recommendations, I don't see you recommending on every objective you came up with. But that's for another discussion. Let's hear answers to what the people said.
Okay, thank you, Chair, and thanks to the participants for the sharp questions. Many were shared, but one from the tutor from Gulu Clinical Officers Training School, that can students participate in field activities, whether to choose or to the clinical officer training. So all public health related training, clinical officer training, which is diploma clinical medicine and community health, nurses, like the public health nurses Prof talks about, are encouraged, and the models for both practicum and embedding onto existing health services, like the outreach models. It's a very good thing, and you can benchmark from other public health training areas. Choose are designed not as students, it's designed as a workforce. And they've finished the training and they're now deployed to commence the fieldwork. Yeah, so thank you.
Mildred, I want to hand over this microphone. So as you give a clap for our panel, I'll hand over to the MC. Thank you very much.
Ladies and gentlemen, a bigger round of applause for our panel and together with the moderator. I think if Dr. Jane Ruth was my teacher, I would have passed better than I passed, because she simplifies the ideas even better. Reminds me more of the simplified definition of what a democratic government is. Government of the people, for the people, by the people. Isn't that what we used to say? And that is the context in which Dr. Jane Ruth actually also brings the discussion that is of the communities, for the communities, by themselves, because then you're going to create trust. There is a bit of peer-to-peer, learning, consultancy, and education, and I think I totally agree with you on that, that if someone tells a message and they're from my community, I relate with them. Don't bring me a PhD student or someone who has gone to school, they're speaking more Gero Luzungu Lunji. That's what the local people always say. Bring me someone who I can relate with in the simplest of terms. So I think you should have been my teacher. Maybe in another world you will still be. You will still. And also what she talks about, cheap things that yield results at the end of the day. Cost-benefit analysis. How much are you putting in? How much are you gaining? Sometimes in particular projects, you could invest a lot, but the output is relatively slower than the investment that you're actually having. Ladies and gentlemen, we need to bring this to a close, but I love this enthusiasm. A round of applause for each and every one of us who is here. It feels like it is still morning, and it feels like we should continue for another 5 hours, not so? Can we continue like for another 5 hours? No, we need to bring this to a close, freshen up so we can be able to prepare for tomorrow. And therefore, because of that, I will need to take on the very last aspects. But totally apologies to the presenters who are meant to come through in our breakout sessions, which we were meant to have today. But we're pulling the breakout sessions that were meant to happen today to tomorrow. So we're going to have a sort of amalgamation of the breakout sessions for today and tomorrow, and we kindly request that you forgive us. But to all our presenters, we kindly request, if you hadn't planned to come back tomorrow, please get back so we can be able to drink from your knowledge. We are going to push those sessions again to tomorrow. But to be able to ease management of these presentations in tomorrow's case, please, we kindly request that you're going to use this email, which I agree that is going to be projected on the screen. Please send your presentations to hpconferenceug@gmail.com. Once again, hpconferenceug@gmail.com. That particular Gmail is where you will send your presentations, so that by the time you come tomorrow, if there are any resolution issues, we can be able to deal with them earlier, because some of the presentations were really, really lovely and people would have loved to follow, but because of issues of pixelation, the people in the audience probably couldn't be able to see them. So if you send them early, that will be very, very good. And also, as we get out, all DHOs and cows, we will request that you meet in Mira. Mira is actually down, so as you take the stairs, you turn to your right below. We will have a meeting with you. There is a word for you, the DHOs and the cows, the chief administrative officers in Mira. And the DHEs, all of you, we meet in Shina. All those are actually right below as we go down. And then some officials from the Ministry of Health, we will request that we all get to meet for a word and briefing about what tomorrow happens in Albert. So Mira, Albert, and Shina are all below. Ladies and gentlemen, allow me invite the Director General, Dr. Henry Jimwebesa, to invite our minister, who didn't just officially open, but officially continued our conversation. But this time she will officially be closing day one of this particular conference. And Dr. Henry Jimwebesa, I'm kindly requesting that you come and invite our minister. This time, she will not officially close the conference, but officially close day one of this particular conference. A round of applause for the Director General.
Thank you very much, Mildred. Honorable Minister, ladies and gentlemen. I want to take this opportunity to thank all of you for your commitment, for your patience, for your dedication, and for committing time to be here up to this moment. You deserve a big clap for yourself. We started early this morning, and we have come up to this time. I know we have left some sessions not completed, but we have agreed we shall complete them tomorrow. So we want to congratulate ourselves that we have really achieved our objective for today. And therefore, this is the right time to close. And for that matter, I'm not going to invite the Honorable Minister to close, because she has asked me to say that exactly. And with those remarks, the meeting for today is closed. Thank you very much. I hand over back to Mildred for the photo moments.
This collaboration is on another level, and immediately the minister was clapping and saying, it's okay, I am not going to come back because I think she officially closed. So I'm going to request that we take a few photos here, group photos, and I'm going to invite the constants in this. Kindly, for our convener, Dr. Kabanda, I am requesting that you come to the fore. I will invite back Dr. Henry Jim Webesa, Honorable Minister, Jen Ruth Acheng. Our keynote speaker, I kindly request that we come to the front together with Professor Omaswa. Now, to this, I am going to invite the first group, who are the heads of IPs and our development partners. Wherever you are, please come to the front, and we take a very fast group photo right here. So all the heads of IPs are together with our development partners. Please let's make it quick to the stage. We might in essence have all our constants up, and then we will have the other group members coming down. So let's have our convener, our keynote speaker, Honorable Jen Ruth. Let's all just come up, and then the other people will be joining us. We'll be taking the front, the lower one, yes. So we could just push to the other end so we don't have anyone crop zoned. So to our development partners and heads of IP, please let's come and join this particular photo. No, you can, since this is a smaller number, we can keep here. The IPs, where are you? Looks like we can't see you in this picture. Okay, you're here. Make sure you're not crop zoned. There is enough space in the back. All right. Our IPs and the development partners can leave this. We will have our constants remain. Let's now have the presenters of the day. Everyone who's been part of the presentations, please make your way to the front so you can also join this particular picture. All our presenters from the morning, please, we are kindly requesting that you do come through and make sure that you can be a part of this photo moment for memory purposes. To all our presenters, please make it to the front. This is memorable because the next time we're having such a conference is 2 years from now. So it is good to have this. If we are very many, we can have a few of us stand behind so we can take a much better picture right here. Yes, we can stand to the back so we can take a much, much better picture, which is well balanced. Now the journalist in me is coming out with a picture moment. Just a minute. Okay, that's fine for all our presenters. Thank you so much for the knowledge impartation. Thank you for the research done. And we believe that by the time we come back in 2024, there is a lot that should have happened with regard to action points on the discussions that we have had. So as our presenters go back, I am going to invite all the district leaders. We've had a lot of representation from various districts, Lira City, Masaka, Kataku. You can talk about all our district leaders. Please make sure that you make it to the front. The chief administrative officers, together with the LCs, together with the district chairpersons. Thank you for the work in... Yes, thank you for the work that you are doing. Make it to the front. All our district leaders, are we done? Maybe the camera team, we can wait just a bit. All our district leaders, the cows, the LCs, the chairpersons, please make it to the front.